Hello everybody, welcome to our public board meeting today. For those watching, I'm Caroline Flint, I'm Chair of the Trust, and we've got a full agenda, and I hope it demonstrates to all of you how much we look at very, very different and diverse aspects of how the organisations run, which helps us to provide the governance and assurance. So without further ado, I'll just start with apologies. We have apologies from Lynn Parkinson, Steve McGowan, Stuart McKinnon-Evans. Declarations of interest. Are there any declarations that colleagues would like to make that cause a conflict for any item on the board? Please let us know. And if you've got any changes to your declarations, can you contact Jenny, our Trust Secretary, so she can update them? Anything anybody would like to declare? No, thank you very much. We'll move on then to the minutes of the meeting held on the 26th of July 2023. Are there any corrections to those minutes? Nope, thank you very much. And we move on to the action log and matters arising. Any matters arising from those? No, thank you very much. Is the board happy to approve the minutes? Thank you. So we have our first proper item, I suppose, of today's board meeting, and it is a patient story. It is about homelessness and engaging in co-production that's helping to develop our services in this area. And I'm really pleased that we've got Kirsty Dent, who's with us. There's Kirsty, nice to meet you. And I think we have a service user who's attending today as well. And we have Mandy who's stepped in. Oh, there's Kerry Draper. Nice to see you. Hello. And a colleague there on the sofa. And we've got Mandy too, who's with us to introduce this item. We've got about 20 minutes, so 10 to 15 minutes for your presentations. I think there's a video, and then we'll have some questions and I think comments. Kwame, you're the lead EMT member for this area. Do you want to say anything before we start?
Yeah, no, I am very excited to see colleagues here. Unfortunately, Haley couldn't be here. I was really looking forward to Kaylee sharing her story and her lived experience. Homelessness service and supporting people with homelessness is really, really key to something that we do in Humber. And it is part of our social value agenda, co-production agenda, and making sure inequality is and equality of access is given to all people who live in our catchment area. So I'm really, really happy to see the team here to share their story with us. Thank you very much, Mandy.
Thank you. So first of all, I'd like to introduce you to Kirsty, who Caroline has already introduced to you, the clinical lead for the homeless mental health team. Kirsty's going to give you an overview of the service that the team provides before we go into a short film. So over to you, Kirsty.
Hi everyone, thanks for having us. I've written down what I want to say because I'll get all muffly and start stumbling around, so please bear with me. So the homeless mental health team is part of a citywide multidisciplinary system in Hull, which works closely with physical health, social care, probation, hostel staff, substance use services and outreach teams. We support people from the age of 16 who are street homeless, precariously housed or living within a hostel. So the service aims to offer mental health support to people who have difficulties accessing the mainstream services, often using hospital emergency departments as the only source of healthcare. Often, health services are not set up to respond to the needs of people who are homeless. So, for example, many mental health services will not treat people until they've sorted out their drug or alcohol problem, which leaves people trapped in a vicious circle of dependency. They try to alleviate the symptoms of their mental health through the consumption of alcohol and drugs, which then means their mental health deteriorates or is left untreated. So difficulties often arise in response to adverse childhood experiences, such as neglect or sexual abuse, which then affects their ability to make sense of the world, tolerate distress and form positive relationships, meaning they quickly become overwhelmed without having the skills, understanding or strategies to help manage these intense emotions. This then leads to, as we've mentioned, substance misuse and addiction, relationship difficulties, which includes mistrust of services, sex working, criminal justice or offending histories, hopelessness, impulsivity, and deliberate self-harm. So as this group of individuals often present with multiple and complex needs, the Homeless Mental Health team try to develop an understanding of the impact of those past traumatic events on current behaviour and coping strategies. So the team recognise that individuals in this group may not be ready to contemplate change or to engage with mental health services. And so we take what is termed a pre-treatment approach that focuses on relationship building, safety and stabilisation. We work within the trauma-informed care framework in order to build up a therapeutic relationship which is built on trust, hope, honesty and partnership working to enhance well-being and resilience. The focus being on what's happened to you as opposed to what's wrong with you. This can take a significant amount of time and people may disengage and be discharged multiple times throughout the process. But when they are ready to access support again, we are available. We operate mental health drop-ins at various locations for accessibility. And there's no pressure on these sessions. They're very informal and focus on giving control back to the individual. Come or don't. There's no expectation. There's no requirement placed on the person. Once the person is then attending more regularly, we then identify goals and specific pieces of work. This then leads to assessment and a forward plan. So our ultimate aim is to get people into a position where they either no longer need services or they're able to access the mainstream services. Thank you.
Thanks, Kirsty. So just to introduce the film, about a year ago, I had a conversation with Hilary, our Director of Nursing, regarding homelessness. Hilary had attended a conference, a national conference, and was very touched by what she saw. She approached me and asked what we're doing to collect feedback from our homeless community. To that end, we set up a working group called our Lived Experiences of Homelessness Working Group, where we have service users, staff, and also external agencies support us with this very important agenda. And what we wanted to do, we wanted to reach out to the community and also to our workforce and the public to share with everybody what the homelessness community actually is all about, how we can support them, how we can reduce stigma, and hopefully this film will give you an introduction into the work that's been going on. So I'll share my screen now.
The city of Hull, a population of almost 300,000 people. A city built on stories of community, close-knit families, neighbours supporting each other in times of need. But on the streets of Hull, there's another story that needs to be told. Homelessness isn't just about not having a place to stay. It's about lives marked by hardships that often began in childhood.
So usually people who are rough sleeping have got multiple needs: physical, mental health, drug use, difficulties with families, managing emotions, and accessing support is really difficult. And it often is that crisis emergency care point when people do come into services. So we're trying to be a little bit different, offer support before it reaches that point and try and get them into mainstream services so it doesn't get to the worst point. This is one of the locations where we would come on outreach. So we work really closely with the Switch outreach team within Hull, and they are the ones who sort of check all the different locations. They're on the ground trying to find and support people who are rough sleeping. They would then contact us as the mental health team if they felt input could be beneficial from a mental health point of view, really. Obviously, the weather is not great at the moment. It's only going to get worse. We're coming up to winter. Conditions are really difficult at the moment.
Every night, individuals in our city face the harsh reality of homelessness, often having suffered complex trauma since childhood. Living on the streets, sofa surfing, or being at risk of homelessness means that these people never feel safe. They can live in a state of constant fear, experiencing things we couldn't imagine. For some, this leads to self-medication, turning to drink and drugs as a way to cope with the trauma they endure. The current known number of rough sleepers in Hull is between 20 to 30 people on the streets at any one time. A further 80 to 100 individuals return to and from the streets on a frequent basis. Plus, there are approximately 350 people in hostel and short-term accommodation in Hull, including the complex needs setting at Russell Street and the hostels at Westbourne Avenue and Great Union Street. The recent closure of William Booth House has put further pressure on accommodation for homeless people.
I think that the hostels do an amazing job, but they really help people to move on. We have had some really good outcomes of people moving on from street to hostel to home. I think people really need the hostels, and it just proves that the loss of the William Booth hostel recently has had a massive impact in terms of how many people we have actually got on the streets, how many people are not able to access a hostel currently at the moment because the waiting lists are massive, and people are not moving on from hostel to home more simply because the housing is not there. We don't have housing provisions as much as we did back in 2-3 years when we first started the homeless mental health team. So we are kind of stuck at the moment in terms of moving people on, but I do think the hostels provide that interim support in the meantime.
In the hustle and bustle of our daily lives, it's easy to become blind to those who are struggling, to walk past them on the street, often because we don't know how or if we should help. They are the forgotten, the overlooked, the marginalised. Their stories drowned out. But health and care professionals are in a unique position. They understand that the faces we pass on the streets belong to individuals with dreams, aspirations, and the same inherent worth as anyone else. And together we can ensure that those in this marginalised position are welcome in services which not only provides people with care and practical support, but gives people hope for the future and communicates that they are valued members of society. Every day, the Hull Homeless Mental Health Team works tirelessly to restore dignity and hope to those who need it most. The people they work with all have a traumatic story. They're often angry and feel like they're continually hitting brick walls when seeking help, especially where addiction is a problem, leaving them feeling rejected, which only compounds feelings of loneliness and low self-worth. But by listening, offering help and support, and by developing inclusive services, even those who feel they have no way out can be shown a path to give their lives safety and meaning.
I found myself on the streets, and then found myself doing drugs every day, and I've been on the streets quite a while. You got a lot of abuse off it, people out drinking. So I used to either sleep down Parliament Street, or else I would sleep on the marina behind this lawyer's place, sleep out the way. Because some of the rough sleepers get out their nut and then attack people that are sleeping on the streets, but so do some drunks. I used to sit and beg, and they used to come, and some people would help you. They'd either get you coffee or sandwich, and other people would give you money, but a lot of people would just look at you as if you were a piece of didn't see a way out. It was just I was on the streets quite long. And then I think it might have been Mellis, outreach workers coming around, and then eventually got into the crossings. And then I thought it's time to come off drugs and sort them out. I moved here, and then like I had to set up like the bows from here, and Kerry's done all that for me, and if she hadn't have done it, I probably wouldn't have done it. I'd have probably been here for a couple of years and then back on the streets. But like she set up all my bills, so it's like it gets paid direct debit, so there's no chance of me losing my place because everything's getting paid. Yeah, the mental health team have been really good. They've supported me and they've helped me to get where I am today. If it weren't for them, I'd probably, I never stepped in and spoke to Emma from mental health, like I would have probably just got kicked out of the crossings and been back on the street. Like, because all before, like when I've been on the street, I never had any support, and like my mental health was very low, and like it's probably halfway at the moment, like, and that's through the help of the mental health.
A mixture of struggling long term with mental health and getting into the wrong crowds regarding drug use, which I later found out was probably self-medicating, and this led to not holding down any work, not living anywhere for any period of time, and eventually, you know, leading to first of all sofa surfing, then spouts of being on the streets, in hostels, and it went on for like that for quite a long time. It had ground me down that much. I was sort of accepting the fact that I was pretty much a nobody, and I was quite happy to sit on the street side and bury my head in a bottle of sherry or whatever, and people not to acknowledge me, and I thought that was my life, you know, and I didn't quite understand how I got to that point, but I started to accept it, and that was a pretty dark time, yeah. When you get people coming round offering you support, and charities coming not offering you support, and saying, like for instance, go online and things like that. Well, I know it seems really natural to everybody to have a smartphone in the pocket, but to even have a mobile phone on the streets is not known. You don't think about having to get to appointments, even though they might better your life. That does not take priority at that time. At that time, what takes priority is you getting through that day safe and well. When I got the flat, without the support of my mental health team, I honestly don't believe I would have kept this property, because when I moved in, even though it was what I wanted, it was all very overwhelming, and I really didn't handle it very well, and I slipped straight into my old way of thinking, and I started drinking. I didn't pick up drugs. I was just heavily drinking, and even in the days when I didn't want to see my mental health team, they came and found me, and I'd even drink in front of them, but they persevered with me. I made a choice to stop drinking and give the flat a go, and with the support of the team, I got it together, and I've really not looked back.
Health professionals can't always treat every wound or heal every scar, but they can offer something more profound, a lifeline. A past can't be rewritten, but we can empower those who feel they don't have a future to reclaim it and make the most of their lives. Through our unwavering dedication, the unseen can become visible, the ignored can become cherished, and the forgotten can find their place in the world. Sometimes it's easier to look away. Sometimes it's easier to walk past. But we're in the privileged position to extend a lifeline to those who need it most.
If it wasn't for them, like, they helped me sort my life out.
It's emotional. It is really emotional. Thinking about what it was and what I've got now is night and day. It's absolute difference.
That's
great. That was great. Kerry, we saw you there. Steve, that was you, I think, on the film there. Thank you so much for participating, and also our thanks to John, who was shown there as well, you know, sharing his journey too. Kerry, Steve, is there anything you wanted to add to what's already been said on the film and by Kirsty?
No, I just want to share what Steve just said. He's just watching the video back. He was just saying how it was nice for him to reflect on his journey, you know, with the team and how far he's come, you know, in these few years. I don't know if there's anything you want to say, Steve.
I don't really know.
Well, we might have a couple of questions or comments, but I mean, it's just so great to see that there is a way out, and that with the right support, we can help to make that happen. And you know, I'm sure on behalf of everyone, best wishes to you, Steve, and to all the team working on this and working with the other organisations who can help make a success of this. That's great. Should we open up to comments and people might have some questions? If you'd just like to sort of raise your hand, I'll pick you up. Hilary.
Thanks, Caroline. What a fabulous film. I say it was a year ago. I went to Directors of Nursing in London. There was a film on that was presented by homeless people with their journeys. And the thing that struck me most about that film was how they could access healthcare, but the way that they were received, and some really harrowing stories with the way that staff treated them, which did upset everybody in the audience, to be honest. And that's what I came back with to Mandy about: how are we reaching out to our homeless community? How are we ensuring they're getting access to good health care, which is one thing. But then the next thing is how we are making sure we're educating our staff about how we receive people that are homeless as well, with respect and dignity. Fabulous film. I think there's more now we need to do with that film across all of our services as well, because homeless people do access our services, how we embrace them, how we look after them, respect and dignity, which is where I think when I met with you, Mandy, that's where I was coming from, wasn't it? What I'd heard I did not want in our service, don't want in any services, but at least we can actually do something about our service. So fabulous story, and thanks to all of those people that have put their stories through on that as well, because that makes it real, doesn't it?
Absolutely, Hilary, thank you. I've got Hanif and then I've got Dean.
Thank you, Chair. Yeah, just firstly echo those comments Hilary's made about, you know, what heartwarming stories they were. My other non-exec hat, as you're aware, is with a social housing provider based in the northeast, and Philip also has some links with housing in Wakefield. But I'm just wondering about our approach to multi-agency work in this arena. The private sector in particular, we know, is very unsympathetic to cases such as those that we've just seen. But the social housing providers generally tend to be better at trying to accommodate these needs. And so the question's really what alignment and links we've got there, just maybe to, as I say, enhance this work even further.
Shall I answer? Is it?
Yeah, Kirsty, that'd be great.
We've got really close working links with our partner agencies in Hull. So we was part of the Changing Futures government funding, which has brought in people from everywhere. Probation, social care, physical health was already in place, but there's more in the substance use services. And there's also within them teams now tenancy sustainment. So if somebody is in a property, to try and help them stay in it. A lot of the, particularly your social enterprise, your housing associations attend meetings with us to have those conversations. And Hull City Council also have like an agreement with the private sector. So we do offer support to private tenants via Hull City Council. That's another branch of the team. Not sure if I've answered your question.
No, I think that's really helpful to know that those relationships are there and still continuing despite challenges. Hanif, did you want to add anything more to that?
No, just to say, I mean, with the housing provider I'm on, the board's beginning to look at how the service becomes more holistic rather than just providing that roof over the head and working with agencies such as the NHS, as I said, to provide that more prolonged support. But it sounds as if from what Kirsty's saying, that's already in place, which is great to hear.
Thanks, Hanif. Dean?
Yeah, thanks, thanks, Chair. I guess it was a similar sort of question, really. I think it was John that was telling that story from sort of unemployment to sofa surfing and then sort of rough sleeping. And in the films and the conversation, we've talked about homelessness and rough sleeping. And just wonder if you could say something, maybe, Kirsty, just about that. I suppose it's similar to what Hanif was talking about, but that's, you know, whether we need more intervention between the sort of sofa surfing to the rough sleeping, and if there's something there about working as an integrated care system, how we can sort of get that right, which is the housing things and stuff that Hanif was saying, you know, the sort of upstream work, really. But a great film, by the way. Thank you.
Thank you. Yeah, there's definitely work to be done. The sofa surfing arena is not even something that we're able to touch on yet, because it's massive. Obviously, you're hidden homeless. We do have another arm of our team, which is housing sustainability, and I sort of touched on it with a mention in private, but that is with council tenants to try and prevent them losing their property in the first instance. A lot of that is around hoarding and anxiety, maybe not having the skills to you know, the life skills to pay bills and make appointments and do those obligations. But there's definitely a gap where the sofa surfing is.
Thank you. Michelle?
Yeah, good morning, everybody. Thank you for a great start. I won't repeat what's in the chat box, but please take time to have a quick look, because it just says how fantastic that video was. It was really great, and thanks Steve and everybody for today. I was just really building on a couple of points that we've mentioned. Is there anything else that we should be doing or that we can do as an organisation, both internally to have that connectivity with some of our other services, but also some of the work that we're doing externally, you know, with place, etc. So there's any messages that you want us to take away that may help with some of the things we've been talking about, housing, facilitation, network, etc., etc. Is there anything that you feel at this stage, or do you want to get back to us? I just think it's so important and it's so powerful that we do need to keep on it, if you know what I mean. As we're working in challenging times, it's important that we keep the messages going.
I suppose the big one, being our ultimate aim to get people into the services, can be really difficult. Obviously, services are stretched at the moment, and it's often they haven't responded to a letter or a phone call and are discharged. So I wondered if there's just a bit of a gap to be a bit creative, if we know somebody's circumstances are more difficult.
Yeah. Thanks. Can I come back on that? Can we take that away then, Claire? Is that something that you can maybe just take away and have a look at and just see how we can just try and facilitate something that you know? I'll leave it with you. Is that okay? Just to take away and have a look at.
I'll link in with Kirsty and we'll have a conversation, Kirsty, about what we can do.
That'd be brilliant, Claire. Thank you.
Okay, thank you very much, Kirsty. Kerry, thank you for all the work you do. Steve, thanks for being part of today. And very much thank you for taking part in that film. It's great to sort of see the work that's being done. For those people who are watching today, I think I can say all our videos available via our website if you want to go, and where we've actually got this excellent video, but lots of other videos that really show some of the services we're providing across the trust, and they're really well made and have a lot of input from our patients and service users. So I recommend that. But thanks very much for sharing what you do in the homeless mental health team. And I think it just reminds us all about what an important part of the work is, and how it shows integrated work can work really successfully if it can be done well with good relationships. So thank you again for coming today. Thank you.
Thanks, guys.
Thank you.
Brilliant.
Thanks all.
Great start to today's board meeting. We'll move on now to my chair's report, and I just want to sort of flag up a few issues, if I may, that are in the report. Firstly, on patient safety, we all of us have discussed as a board the issues surrounding the Countess of Chester Hospital and the finding guilty of Lucy Letby. It just so happened that we had, as we know, a strategic board meeting in August where patient safety actually really dominated most of the agenda in different ways, and we, in some ways, it was an opportunity to reflect on the Countess of Chester situation, and we'll talk more about that today. And I think it just shows us that for all the systems that we might have, which are really, really important to provide assurance, to make sure incidents are reported, to look at the data, as we all know, and we've been talking about this and working on this, and Hilary and others have been doing an excellent job. It's also about the cultural side of this, about people being able to speak up, about people being listened to. And that is never a job done. It's a continuing part of the work of our trust, as we know. But I would also say that for some of us staff, and I've said this in my report, this situation and others that have come to public attention quite rightly in the last year, and there will probably be more in the future, sadly, should be seen also in the context that every single day, millions of people are helped in the NHS. We are helping people every day in our trust safely. And that is not to say that we are complacent, but I think for staff who are doing a good job, who will always speak up, thank you for the work you do as well. And we've just got to make sure we continue to keep that high standard of engagement, transparency, and to be a listening organisation, which I believe we are. But there'll be more on the agenda about that later today. We have gone through a recruitment process this summer for 2 new associate non-executive directors. I'm pleased to say in September, the Council of Governors approved the appointment of David Smith and Priyanka Pereira, who we are due to start hopefully in October. But it also means we're saying also goodbye to Hanif Malik, who was our first associate non-executive director. And we'll have another opportunity, I'm sure, to have a chat and share our thanks. But just, I suppose, formally for the board, Hanif, I just want to say on behalf of everyone, I think we all individually and collectively have really benefited from your experience and your commitment actually in this role, to be really involved in our discussions over the last 2 years and the ideas that you've brought forward about how we can think a bit differently about different issues, but also look at gaps where we could do more. So I just want to say thank you so much, and we wish you well in everything else that you do, and you'll be missed. So yeah, are we going to see some virtual claps around the room?
Thank you, Chair.
Brilliant. Hanif, did you want to say anything?
No, I've really enjoyed my my 2 years. I hope I've been able to make a contribution in a small way, and I suppose I leave with some regrets really in that I've not really been able to fulfil the role as thoroughly as I would have liked. I'd have loved to have done some more work with Mandy on patient care, with the EDI group, and even with the youth group, all of which were areas of interest, but sadly it proved not to be the case. And I say this not in a patronising way whatsoever, but the colleagues I've worked with, both on the exec and non-exec, have just been brilliant. And I think the trust is really well positioned moving forward with the calibre of people that we've got here.
Thanks, Hanif. Thanks very much. As I say, we'll have an opportunity to more privately say our thanks as well, and wish you the best. Couple of other points. Governor elections are underway. Massive programme of comms going on. I'm going to be on the radio tomorrow promoting it. Nominations close on the 17th of October. So anybody with any networks, please share the information that's available to encourage people to stand across the different constituencies. We've got vacancies for staff, we've got vacancies in Hull and East Riding, and a vacancy up in the newly formed Whitby, Scarborough and Rydale as well. So everything else is in with my report. Any questions? Mike?
Yeah, just a quick point of accuracy, Chair, and that's that you've got down that the Government Development concentrates on mental health ledge. That was deferred at my request, but it will happen again.
Thanks very much for that, Mike. Yes, that was my mistake. That will be happening, a discussion about the work of Mental Health Ledge, and we're looking forward to that. We actually did do a session, which Mandy was at as well, which is with sharing with governors all the different ways in which we get feedback from patients and service users, which was really helpful. And in fact, the presentations at the last Governor Development session and the slides that went with them were really informative, and I think they've been shared with all governors and with the board, and we're going to use that actually for the inductions for new NEDs, the associate NEDs and new governors going forward, and well done to the staff who did that. Thanks Mike for pointing that out. That was me getting ahead of a situation and making a mistake in my report. Okay, I can't see any other hands up, so we'll move straight to Michelle's report, Chief Exec's report.
Thank you, Chair. Okay, good morning, everybody. There's a lot in my report, so I'll only pick out relevant headlines. So please do, other executive colleagues, do chip in as you feel free. We've got quite a lot of policies to approve. I think there are 6 in total. We'll come back to those at the end. It's great to see in the reports the leadership visibility pieces throughout the report. So thank you again for that. And I think that just demonstrates how the executive and how everybody in the organisation is trying to get around our vast site. So thank you for that. I think some really good observations. Fantastic news that we've been shortlisted for a HSJ award. Being a judge, I know how strict that process is. So fingers crossed for that. And that's for the right care, right person, which we continue to do a lot nationally and internationally now on that front. And I thank everybody that's been involved with that. Obviously still working through it, still developing the model, but as I say, getting a lot of national and international press. Always there's some appointments in there. I won't go over there, but please familiarise yourself with some of the changes taking place across the place and the system. There's quite a big piece in there around the Sexual Safety Charter. People will have heard about and seen the Sexual Safety Charter from NHS and the reports that have come out from the medical side. It's on page 43 of the pack if you're in good reader, so please have a look at it. And Hilary leads the sexual safety work. We're going to have a more detailed conversation at the exec in relationship to how we mirror the detailed work that we've been doing around patients and also the work we've been doing to staff to avoid duplication. But there is a big update on that, and it also gives the current position. And I'm sure Hilary may want to pick that up. But again, it links into the cultural work of the organisation, being humble, and all the behavioural frameworks that we've got. And it's about adhering to those, leading with those and developing those as we go through. Culture is so important, as we mentioned in relationship to the Countess of Chester report. It's flu and COVID vaccination time now. And thank you to Karen and Kwame. That work has started. We'll start to get some data on that to the exec team. Lots of peer vaccinators around the organisation, and we will have specific COVID sessions as well. It is important that we all as individuals stress the importance of being immunised both against the flu and COVID. COVID figures are increasing as are admissions with COVID as well. You will notice by the background, the patient safety incident response framework. I know we've had a training session on that at the exec. Thank you sincerely to Hilary and her team for the work they've done on that. It's a massive change from the current incident reporting system. A lot of it we were doing already in relationship to engaging with the families, etc., but it is a huge undertaking, and obviously the hard work will start in October when we go live. Just to remind the board, it is a mandatory training in your inbox, so please have a look at that. I've done it, so please have a look at it, but everybody else is expected to do it. Respect campaign, again, it's one of the things that Hanifa will really miss. Hanif really been helpful, that started us to think about the respect campaign. Hanif, we've started that now, so I'm sure you'll know, hopefully leave us knowing that we've actually enacted some of those. So I'm sure Karen may want to pick up a bit of that alongside the people strategy as well, that we're doing a big engagement piece of work. Engaged for the Rainbow Badge and occupational health accreditation again, which is so important. Again, thank you for the team. A little bit on there about wage stream. This is how we pay staff after they've done immediate shifts on from the bank point of view. It's going down very well. Thanks to Pete and the team for that. And there is a detailed cyber update. Obviously, the friends and family test are, if not for friends and family, fitness of the board members is also on there as well. The friends and family is very important, and we have been doing some work on that recently. Lots of work on comms, which I can't do justice within a couple of headlines, so please have a look at that. Thanks to the comms team. Two important things: the chairs are already related to the governor elections, but also the annual members meeting as well. And there's some charity update on the charity there. So just the 6 policies, unless my colleagues want to ask any, increase on anything that I've said, expand on anything that I've said, and I'm open for questions as always. So thanks. And Hillary's already got her hand up. Thanks, Chair.
Thanks, Michelle. Hillary.
Thank you. I just wanted to let the board make you aware that last Monday it was the HSJ Patient Safety Awards. We had 3 nominations in that, and we got highly commended for our learning disability team around an initiative that focuses on enhancing the quality of care for people with a profound and multiple learning disability. So that was really positive for us. There was an awful lot of nominations in there, so to get highly commended, well pleased with that.
That's fantastic, and congratulations to the team. What's the name of that programme they've got, Hillary? Is it for the learning disability? Is it follow up or step up or something? I think. Am I mixing it up? Don't worry, let me know later.
I don't know. Yeah.
Okay, Pete.
Yeah, thanks, Caroline. I was just going to pull out. Really pleased to say we took delivery of our first fully electric fleet vehicles last week. I've put a picture in the chat box. We've got 14 in total covered, and it supports our Green Plan agenda, which is really important to us as an organisation.
Brilliant. Thanks very much, Pete. Anybody else would like to add to something on the report they'd like to flag? Claire's with us today. Thank you, Claire, for being here. Lynn's away on leave. Claire?
Yeah. Hi there. Just to pull out about the industrial action that's ongoing. We saw our first joint industrial action last week with...
Oh, Claire. Can't hear Claire.
Incidents to date.
Claire, do you want to say that again? I lost you. I don't know if everybody else heard you.
Yeah, it froze.
Oh, did I freeze? Sorry.
Yes.
I was just saying that in terms of from an industrial action point of view, we saw our first joint industrial action last week with the consultants and junior doctors, and we're experiencing more next week. So it's just to say that from a Silver tactical point of view, we're managing that well and with no adverse incidents to date. So I just wanted to point that out.
Thanks very much, Claire. Okay, Mike.
Yes, thank you, Chair. It's a question on Kwame's part of the report, if that's okay.
Yeah, sure.
And it's we're very pleased to see the pilot area for the Quality Improvement Scheme on the Mental Health Act and the new Mental Health Act that's coming forward. So just a question, a comment question that's within the purview of Mental Health Legislation Committee, so I'm sure we'll get a briefing there. But then the comment is, if there's any way I can get involved in that from an assurance point of view, just shout.
Thanks very much, Mike. Kwame?
Yes, Mike, I was having a chat with Caroline about this yesterday. I was trying to give you chance to recover, but if at some point I'll be happy to have a meeting with you to explain to you what the program is about. So, yeah. No, just pull out the fact that research, as you know, we've always punch above our weight with research. We're getting 4 nursing students to join our research to be able to grow research for the future. One of the things which I wanted to highlight was when a neighboring trust approached us, having seen our feedback from GMC, to see that we are on the top 10 in the country to see what we are doing, which is a bigger trust, much bigger trust approaching us to say, what are you doing? Which makes you have these fantastic results from the GMC. So we were completely chuffed, and I wanted to pull that out the board.
Thanks very much. That's great to that's really great to hear. Thank you. And just to flag also on quality improvement, our next strategic board meeting in October, we've got on the agenda actually some training on quality improvement, and that for all the board is part of the agenda for that day. I've got Dean, and then I've got Francis.
Thanks, Caroline. Just to say, very happy to support the signing of the sexual safety charter and the commitment from the board to that. I just wonder, by way of an action, whether once a lead is identified, whether it may be appropriate to pull together a bit of a sort of action plan. There's some of the actions in there about sort of reviewing policies and providing training support and reporting mechanisms and those sorts of things. And I think Michelle, that sort of timeline into next year makes sense to do it well and properly. So, sign up to the commitment and then follow through with the actions, I think. But thank you.
Yeah, thank you for that. I can see Michelle nodding there. I think that's a good idea for all these things to have an action follow-up. And just to say as well, Michelle and I have had a conversation about this too, and I'm going to also meet with some people to talk through some of the work in this area. I mean, clearly, we do need to be absolutely mindful about where people are feeling compromised and being sexually intimidated in any organisation. But here in the Trust, we need to assure ourselves that people feel open to speak up, whatever form that sexual sort of intimidation might take, that we are open to hearing from people, and people know that this is just not acceptable. This is just not acceptable at all. And obviously sexual harassment overwhelmingly often affects women, but it can affect some men as well. But it is usually, in most circumstances, also men who are the perpetrators of this. So it's not in line with our behaving humber, it's not in line with our culture. And that message needs to be made very clear, and we'll be doing work on that alongside our other sort of behavioural standards that we expect to create a good workplace to be in and a good place to have services. Francis.
Thanks, Chair. Just a couple. One in Lynn's area, which also plays into something later on the agenda. It's good to see that there's going to be some extra money for winter as ever, but I'm just sense checking. I don't think it's ever dropped in terms of the pressure since last winter, has it? You're experiencing it's almost the new normal, isn't it?
Francis, thanks. Yeah, who'd like to come back on that?
I'm happy to. I'm sure Claire will. Absolutely. It's something we've always said, that we've just gone from all the way through, and it's just slightly different demand in a slightly different area, but that it just continues to peak. In fact, we had quite an interesting paper that Claire and the team have produced about children and young people, about waiting lists and the capacity and demand, which will come to a board strategic session at some point. And it is quite, it's quite concerning in relationship just to the numbers and the demand. So you're absolutely right, Francis, but I'm sure Claire will expand a bit further.
Yeah, I think in terms of later on the agenda is the winter plan, and I think it's a case of it is the norm, pressure through the system all year. It's just how we respond to the different aspects, in terms of depending on the time of year. So I think in terms of we've got a number of initiatives in place to try and bolster ourselves ready for winter, but it has been pressured all year.
Okay, my next one was with probably with Karen. Just wondering when the leadership conference and the big OD conversation was likely to be. It's good to see it's in there. Just wonder when you're planning it.
Yeah, so we're working up the timeline now, so I think they're quite meaty pieces of work. In terms of the conference, I think in EMT we agreed that we would kind of look to maybe the spring of 2024 so that we can really take a good bit of time to plan it appropriately and make sure that we've got the right speakers and the right engagement. In terms of the big OD conversation, again, probably after Christmas. We're all in the planning phase at the moment. So like I say, watch this space for that, but it's some really exciting pieces of work.
Thanks. And my last one was to Kwame, just say well done, and probably to Hilary as well on the nurses being involved in R&D. That looks like really exciting to get them so firmly embedded in that. Excellent work. Thanks.
Great. Thank you. Right. I can't see any other hands up, so thanks for that. A number of these issues are going to, in the Chief Exec's report we've got on the agenda later on, so we'll come back to it. So we'll move on to publications and highlights report. Michelle? Anything
sorry, can we just agree the sorry, Chair. Can we just sign off the policies?
Apologies. my apology, my mistake. Thank you. We've got a number of policies to ratify today. I'm just going to, I'll go through each one, and if you could just indicate if you're happy to ratify. Vehicle tracking policy. Yes. Local Clinical Excellence Awards. In favour. Patient Safety Partners Policy. Happy to ratify. Yeah. Attendance Management Policy. Happy to ratify. Yes. Physical Restraint Policy. Yes. And Patient Safety Incident Response Framework Policy, which we've had a lot of discussion about over the last few months. Yes. Thumbs up all round. Brilliant. Thank you for that reminder, Michelle. So we've ratified those policies. So we'll move on to publication highlights. Michelle.
Thanks, Chair. Again, I'm not going to pull anything out. It's here all the major publications that aren't referred to in the Chief Exec's report, and which director is signed to that document, and a bit of an update. So if there's any questions, I'll go straight there, Chair.
Any questions? Francis?
Just a comment more than a question. You can see now what we discussed in terms of a central desire to try and cut costs and reduce the financial. We knew it was going to come, but you can see, looking at some of the stuff in here, that they're obviously going down that route in quite a big way.
Yeah, yeah. Dean?
Apologies, Caroline, I just wasn't quick enough on the buzzer, but I think it was implicit in the paper and the discussion we had. But do we also just need to explicitly confirm support for the signing up of the Sexual Safety Charter as a board?
Okay. Yes, thanks, Dean. Yes, we'll take that as we are officially as a board approving the signing of that charter and an action plan being produced out of the meetings that are taking place to discuss further action, and that'll come back to board. Okay, thank you, Dean. Right, okay, we'll move on then to Hilary and Kwame, patient safety, item 9.
Do you want me to go first, Hilary?
Yeah, fine.
Yeah, I mean, this is, again, from what we have already spoken about, it's one of those cases which come into the NHS and you listen to it, and as a clinician, your heart sinks, because this is not what people come into mental health or become a clinician to do. This paper, it is not to say that this is the only thing that we do in the trust, but this is to say there are additional things which would come into force in order to make sure that we keep our patients safe. So everybody knows that we're doing some work on the close culture, which Hilary is leading. We do a lot of patient safety work, which including PSEF, which we all have on our background, which include our risk safety arrangement in organization, freedom to speak up, all the visibility and the ward to board visit that we do is all part of the and then all the things that we do. However, there are other things which has come into force, which is called the Medical Examiner's Office, which was supposed to have started from the time of Shipman, but it's taking a long time. And the medical examiner would examine every death, which doesn't have to go to the coroners, which would include GPs and even people on our waiting list being reported to the medical examiner, who would then decide whether the further investigation needs to happen. We have met with the medical examiner from both Hull and East Riding and York and Scarborough, which is within our catchment area. And we do understand the process, and we're working with them to make sure that when the process kicked off from the 1st of April next year, we will be in a good state to be able to support the system, because they're a good system, actually. As part of the paper is an item which fit and proper person, new ideas which has been put in place, which Stella has added to it. And I wanted colleagues to be aware of some of the things we are doing, in addition to all the things we're doing. If there's any questions or any comment people want to make, Stella, Hilary, on this paper.
Any comments? Francis?
Just reading through everything, it's a really good report, but in terms of speaking up, we explicitly, it says about making sure that in the letter that we listen to the concerns of patients, family and staff, and the speaking up section deals specifically with families and staff. but there's nothing explicit about patients. Obviously, the patient safety incident is when an incident has happened, so that's not in advance. It just doesn't explicitly. I know we do a lot with patients, but it doesn't explicitly address that bit of the letter in the paper. That's all.
Kwame?
We do quite a lot of things in terms of our patients, and some of the things that Mandy is going to talk about, it would highlight on the feedback we get from patients and families and carers. But I take your point, and I'm happy to incorporate that.
Thank you, Michelle.
Yeah, no, I think you're right, Francis. I think we need to be a bit more explicit, but we do a lot through the work that Mandy does through the patient forums and the coordination forums, and also we had a really good report to the exec team on Monday that clearly demonstrated the safety culture, where there's a lot there in relationship to near misses that come from both staff and patients as well. So I think we just need to quantify it a bit more really and put that assurance in there. So I think it's a really good point, and it's a good point for us to look and just see what else we can do as well in relationship to that. But thanks, Francis, very helpful.
Thank you. Okay. Shall we go on to the next paper, Close Cultures?
Rachel, I picked that one up. I mean, the two papers go together, don't they? I mean, one paints a picture of a harrowing story, which sent shockwaves across the NHS, as it did with Beverly Allett, Harold Shipman, Colin Norris. It's very difficult to put governance procedures in place to out a criminal, because let's face it, that's what Lucy Letby is. But it is all about that cultural piece, about people spotting things that just don't seem right and feel confident to raise that they've just got a concern. And then it's not just about raising your concern, people listening, it's about acting appropriately. And hopefully with our changes with PSAFE, with that real focus on theming things up, looking at trends more, because we won't be doing such detailed investigations across the piece, it will be far more proportionate. We should have more capacity to be able to start theming and trending things more. I mean, we've always done it anyway, but it really is that focus on that now. We would pick things up like that as well. So the Closed Cultures report, this is the third report that I've brought to the board. Since Edenfield, obviously it pulls in from all the things, and the Letby stuff will all pull in as well as we hear more from that, and we get the outcome from the inquiry of Edenfield as well. We will constantly build on this, and I think with all of this work, we will never lose sight of the people that have been affected, particularly by the Letby case. And that harrowing case, we won't lose sight of that. We're not just going to become sort of, oh, let's in governance. That is about people here, isn't it? And we won't lose sight of that in everything that we're doing, about trying to improve everything that we've got. So that the Closed Culture builds on, as I say, all the work that we've been doing now for nearly a year. Next month will be coming up to a year where we've had that really strengthened focus on it. The reducing restrictive interventions work is going from strength to strength, and again it's about data, which the Letby and a trial has picked up about that data as well, and triangulating it and theming. We've got an improved draft now around what we're looking at. How we look at reducing restrictive interventions. That's coming to the fore and should be ready to go to mental health legislation when they next meet. The Safe Wards work is becoming embedded in practice as I'm going out. I'm seeing evidence of that. I'm talking to staff about it and what it means. The visibility is I think COVID, that's where we really sort of, everybody, just how it was, wasn't it? We couldn't be as visible as we wanted in terms of face-to-face. We made up for it, obviously, with visibility around Teams, but it's not quite the same, is it, as going out and seeing and talking to staff and meeting staff that maybe you wouldn't normally meet on Teams. So as you can see in the report, lots more of that visibility piece, but also about out of hours visibility and a real focus on that. And again, the board will be picking that up as well. And that whole culture piece, again, we had so many discussions with staff around Edenfield when it happened, Closed Cultures, etc. And as you can see from the report, lots of sessions being put on with new staff, new starters, newly registered staff, to really get that cultural piece out there, but also what it is about Humber and our value set being Humber, our behavioural standards, and that is our real focus around that cultural piece. Again, Let Be Happening was another opportunity for me to be speaking to staff. Are you talking to your staff about it? Are you really switched on when staff are raising concerns? What are you doing about it? So these, I think, as we all go out on our visits, are the sort of discussions we should be having with staff to really make sure that they're listening to what's being said to them, and really using some of the instruments we've put in place. The Datix is real-time Datix reporting when they're reporting incidents that they can look at themselves, and they can look at themes and trends in their own services, not waiting until we look at them perhaps monthly or quarterly. So they should be picking that up themselves. So these are the discussions I'm having with teams as I'm going out as well. So reports there, it's quite a big report, obviously, because it's covering the whole trust and everything we're doing. I'm just happy to take any comments, questions on the report or anything I've said.
Thanks, Hilary, and thanks for all the work you've been doing for the whole year, last year with your team. I mean, it's tremendous work that's been done, both to, assure ourselves what is already happening, as well as looking for ways to improve or make some changes. Thank you. Mike, and then Francis.
Thank you, Chair, and thank you, Hilary. I welcome this report, and we always ask ourselves the question, could this happen here? And the answer is yes, it could. But as far as assurance is concerned and trying to prevent that, I'd like to compliment the work of the restrictive interventions team and the reports that they've produced, because when we talk about this triangulation, it's about the real world. And we get a lot of case studies within the RRI, Reducing Restrictive Interventions report, which really paints a picture for us as lay people as to what's happening on units. I was thinking, and I'm not being critical about this at all, that we see loads of good practice, but it may be an idea at some point to bring a case study about something that went wrong and how we dealt with it. But I really, really feel assured about this. Of course it can happen, but the systems, procedures in place and the culture, which is really important, is something that's brought to our attention all the time. And one last thing, particularly in terms of panorama and seclusion, we do see seclusion reports. We get anonymised data about long-term seclusions and the reasons behind that. And we also do seclusion audits, which have been designed in conjunction with the staff, which is another form of co-production about how do you audit something in a form that the staff can do. So thank you all for the work on that, and long may it continue.
Thanks, Mike. Francis?
Yeah, I'd just, first of all, like to echo Mike's comments. Excellent report, excellent work. So really well done to the team. And just a minor question, when we are on our visits, is it okay for us to ask to see the quality improvement plans that you mentioned in there when we're out and about?
Oh, it's absolutely, yeah, absolutely. Should be asking teams about what quality improvement initiatives they've got, yeah, and the support, all that seems the right things to be asking teams, yeah.
Thank you, Hilary. Michelle?
Thanks for the papers, and thanks for the conversations about this. I know that we've had a lot of conversations as a board about it. Just to reiterate what we've said, I mean, for me, as you know, my passion about the cultural piece. This is everybody's responsibility, and I know that everybody around the table knows that, but it's about how we constantly working on our culture. Yes, we need policies and procedures and governance frameworks and assurance, but it's how we support our staff members and our patients and our carers in relationship to that honest, open and transparent approach. And I thank everybody, because I think that, we're constantly thinking about that from an exec team point of view. We're constantly looking at how we can, continue to develop that, because I think Mike's absolutely right. We can never say that will never happen here. We've just got to be constantly asking that question and never get too complacent, either with the things that we do and the awards that we get and the fact that we get shortlisted. It's always that continual learning, continual assessment. And again, I thank everybody for the work on this, but the cultural piece is that ongoing piece of work that we never get to the end of, if you know what I mean. It's that constant cultural piece. So thank you, everybody, and thanks for the comments and commentary. Let's keep it on the agenda and let's keep talking about it.
Yeah, thanks very much, Michelle. Freedom to speak up is really, really important, but actually it starts at the point where people are actually working and delivering services. and that's, you know, a focus of all our attention, I think, in this space. Thanks very much. Great. We'll move on then to item number 10 and 11 together on patient care experience, 5-year forward plan and the annual plan. And we've got Mandy with us. Can we go straight to Mandy? Kwame, is that okay? Thank you, Mandy.
Okay, thank you. So just to introduce, first of all, the 5-year forward plan. It's been a 14-month process where we've co-produced the plan with a wide range of stakeholders, patients, carers, service users, our diverse community groups, staff, partner organisations, etc. There are 2 versions of the plan. We have an internal plan, which has our trust milestones broken into each of our 4 divisions, as well as trust-wide, which breaks down into 3 time trajectories. So milestones over years 1 and 2, years 3 and 4, and years 5. So you can see exactly what we want to achieve to deliver the plan over the 5-year period. We've got a number of resources to support the plan as well. We have currently developed an easy read version of the plan. We've got a film which I'm going to share with you today, which is just over 3 minutes long, which brings out the key messages in the 5-year plan, a patient information leaflet and posters to go up in all of our units, bases, etc. And finally, 4 pull-up banners which span the 5 years that we have just undertaken our 5-year patient and care experience strategy 2018 to 2023. So it shares with you the key milestones of what we achieved to deliver the last strategy. So you can see where the where they dovetail together for a 10-year period. So I'm going to share my screen now to share the highlights of the plan.
We are delighted to introduce our new patient and carer experience forward plan. Our communities are at the very centre of everything that we do. There is no better and more important way of improving services than by listening to what individuals think, feel and experience throughout their care journey and beyond. This forward plan will set out how we will listen, support and work together with our patients, service users and carers.
As a service user, carer, governor and a patient, I am passionate about improving services within the Humber Teaching NHS Foundation Trust. We are on a journey which changes and improves each year, but the main focus is always the care of the patients, service users, carers, staff and the community.
Over the next 5 years, we will achieve 3 outcomes.
Our care is informed by lived experience, involvement and engagement to ensure our diverse communities feel heard, valued and understood.
Our strong partnerships enable us to empower communities, address health inequalities and deliver integrated care that meets local needs.
Our staff are supported to involve our communities in all aspects of our work.
Across the Trust, we will pay people with lived experience to work together as equal partners with our staff to develop and improve services. Patient information will be produced in partnership with our patients, service users and carers across all services. We would work with our partners across Yorkshire and Humber on joint projects.
Children and young people will be able to access the Youth Recovery and Wellbeing College, Humber NHS Cadet Programme and work experience in our Trust.
Patients with learning disabilities and our families will help to train staff.
We will improve engagement with carers and family members throughout our forensic services by hosting open events and promoting family engagement training for our staff.
Patients and carer experience champions and volunteers will support our community hospitals, GP practices and addiction services to collect feedback to enhance patients and carer experience.
Our Humber Recovery and Wellbeing College will empower local communities, including people experiencing health inequalities, to support their own mental health and well-being.
I get the last word, but it's your voices which count. Over the past 5 years, your involvement and engagement in trust activities has helped us to significantly improve the care we provide to our communities. Moving forward, our patient and carer experience 5-year plan will guide us to continue on this journey. Thanks to everyone who has contributed.
Thank you. I'm happy to take any questions.
Any questions from colleagues? Great video. Shame about the woman at the end. Mike.
Yes, yeah, just a comment. Great video right at the end. QR code, wonderful. I asked about this about 4 or 5 years ago, and it's been being used extensively. Great stuff. Thank you.
Thanks, Mike. Any other questions, comments on that? Brilliant. It's a really good document as well, and the 2 versions, I've been through them both, and thanks very much for that. Michelle.
No, just quickly, this does link into the first of the 2 items we've just been discussing about closed cultures and counters of Chester. So it's really, it's vital. So it does link through, but great video. Again, I'm not so sure about the lady at the end, but the woman at the front wasn't particularly good. But anyway, we'll move on. But thanks, Mandy. I don't know why I get people to do videos, but anyway, thank you. I feel I'm being put upon now. I can say that about myself. Right, okay. Mandy, that's great. Mandy, do you want to go on to the annual plan?
I will, yes, thank you.
Thank you.
So the annual report 22-23 gives an overview of everything that we've been doing across the trust to involve, engage our patients, carers, service users, and of course our staff. We co-produce with staff too. It gives a flavour of all of the work going on, right to the intricate detail of the divisions. So again, another report. This time it's an animation report, so we've got a little bit of variation, so we know which report, which film goes with which report. So I'll share my screen to pull out the highlights and then take some questions at the end.
And Carer Experience Annual Report, April 2022 to March 2023, including the Complaints and Feedback Service, provides an overview of the work carried out across the organisation over the year to support the patient and carer experience and engagement agenda. The report also provides an overview of the Complaints and Feedback Service for the 12-month period. Analysis of the themes from complaints and concerns is used to identify areas for learning to improve patient experience. Throughout this film, we will refer to our patients, service users and carers as communities.
Involving our communities in all that we do has become an integral part of our culture and everyday thinking. We actively listen to people from all parts of the community, with equality and diversity woven throughout the patient and carer experience agenda. Due to the vast range of diverse services we provide, there is an immense wealth of knowledge that we can access from our communities to help us with our improvement journey and transformational plans.
We continue to host regular forums to enable our communities, staff and partner organisations to be actively engaged with the Trust. We have expanded the number of involvement and engagement groups that our communities can access to share their experiences and get involved in Trust activities. During the second half of the year, the Experience of Homelessness group has been meeting to develop an approach to listen and engage with anyone who has lived experience of being homeless. By listening to the voice of those who have lived experience of homelessness, it is hoped that we can raise awareness of the issues surrounding homelessness to enhance the support we can give. Last year saw the launch of the Patient and Carer Experience Training Programme, where individuals can access training resources to develop their knowledge in trust activities. In October, we were delighted to welcome back our forum members to face-to-face meetings where a celebration event took place to recognise those who completed the full training programme.
We continue to invest in the patient and carer experience agenda. Engagement and involvement leads work in the Trust's 4 clinical divisions to support teams to actively involve our communities in their work. In January, we launched the Experts by Experience opportunity to enable people with experience of using our services who are involved in projects to be paid for their time. The Trust's Family Inclusive Care Coordination Refresher Training now features the story of a family member who lost a loved one to suicide. This enables staff to use lived experience to reflect on how they involve families in their practice. New work which has been developed in partnership with people with lived experience can display our Trust's co-production logo. This adds value and recognition to the hard work and support that goes on behind the scenes to co-produce work and to showcase where co-production has taken place.
Integrated Care Systems, ICS, are partnerships of organisations that come together to plan and deliver joined-up health and care services and to improve the lives of people who live and work in their area. The Humber and North Yorkshire ICS is working with NHS England and the King's Fund on an engagement project. The project aims to bring people's voices into the ICS. 5 organisations, including our Trust, are leading on this work, and we will be working with organisations across Humber and North Yorkshire to develop a shared vision for experience. To help us understand who is accessing our services and their needs, November 2022 saw the launch of a data collection template designed to ask patients and service users demographic questions to help us personalise interactions and conversations. This information will also help us to better understand who our wider communities are so that we can strengthen relationships for partnership working. Over the last 12 months, we've engaged and involved our communities in the development of our Patient and Carer Experience 5-year forward plan, 2023 to 2028. This plan identifies 3 outcomes aligned to the Trust's 6 organisational goals and highlights what we will achieve over the next 5 years across patient and carer experience, involvement, engagement, equality, diversity and inclusion.
Patient and care involvement in quality improvement activities across the Trust has grown over the past year. At the end of March 2023, 147, 61% of improvement activities were identified or delivered with our patients, service users and carers. This is an increase of 17% over the past year. In addition, 93% of open and completed quality improvement activities suggest that they would benefit our patients, service users and carers.
This year, the Trust has responded to a total of 582 complaints, 195 formal complaints and 387 informal complaints. For the same period last year, 2022, the Trust responded to a total of 535 complaints, 235 formal complaints and 300 informal complaints. On comparing the 2 years, there has been an overall increase of 47 complaints. Communications, appointments and patient care are the top primary subjects. The Trust has seen an increased use of the informal process, which results in a swift resolution. Of the 195 formal complaints responded to, 46, 24%, were upheld, 58, 30%, were partly upheld, and 91, 46%, were not upheld. For the previous year, the Trust responded to 235 formal complaints, of which 37 were upheld, 16%, 68 were partly upheld, 29%, and 130 were not upheld, 55%. 36 of the Trust's 107 clinical teams, 34%, did not receive any formal or informal complaints during the year. Patients, service users, carers and families sometimes compliment our staff, offering their gratitude and thanks for the wonderful service they provide. The Trust received 243 compliments for the period April 2022 to March 2023, which compares to 304 compliments received for the same period during 2021-2022.
If you would like to view the full annual report, you can either scan the QR code on this page, visit the Trust website at www.humber.nhs.uk, or telephone the Patient and Carer Experience Team on 01482 389 167.
That's great. That's great. Thanks, Mandy. And just to remind everybody, Phil's put it in the chat box. Both these plans have been to the Board Quality Committee, so they've been through that assurance process as well. And just to say thank you to Marilyn Foster, who's one of our patient and care experience governors, who's been involved very much. You saw her on the first video and you heard her voice on the second animation as well. So thanks, Marilyn, for all the work you do. Any questions or comments from colleagues? Francis and then Hanif.
Just a quick one. In your overview, you talk about the work that you've been doing in primary care and phase 1, phase 2, phase 3 pilots. Just wondered how that was going.
Yeah, the Scale, Spread and Embed project is going really well, thanks, Francis. It started with Market Wheaton as our pilot practice, and it's now rolled out across primary care. We had our launch event last week. So all 3 practices are now on board, so they'll be having regular meetings with the teams, quality improvement, business intelligence and the patient care experience team. We plan, as soon as the organisation has moved over fully to Power BI, we will be launching the thematic analysis approach, a new dashboard across the whole organisation. So every team in the Trust will be able to see their dashboard for their team of the feedback from the friends and family tests coming in, and the thematic analysis, which is positive and negative analysis, and it's aligned to the 8 national patient experience themes. So it'll make it a lot easier for the staff to understand the feedback without going into each. They obviously can interrogate the data, and I expect them to, but they'll get the thematic analysis to inform quality improvements and etc. And the idea is they'll work with Kath's team on the quality improvement charters.
Thank you. Thank you, Francis. Hanif and then Phil.
Thank you, Chair. Great reports, Mandy. Just a comment, really. One of the areas which I got involved with and didn't really have time to fulfil as I would have liked was the youth group. And I suppose it's just almost a parting plea, really, that in terms of competing priorities, and we've focused on patient complaints, CDI, and those are the really important areas, that it's not an area that gets left behind. You'll have to excuse me, Mandy, I forget the name of your colleague who I had 2 or 3 meetings and discussions with, but she was so passionate. That's right. Thank you, Chair. She was so passionate about the group. And obviously we've, as a board, collectively seen 1 or 2 of those individuals present their stories. But yeah, as I say, it's just this comment is my last meeting that, I think it's one of our stars, amongst many stars that we've got in our armour, but one not to be forgotten, that can quite easily slip off the radar when we're focusing on some of those bigger headlines.
Yeah, absolutely, Hanif. And Beth here is doing an incredible job with the Humber Youth Action Group. It is going from strength to strength. They meet at least every 6 weeks. There's a lot of work going on with the group in the background, as well as their regular meetings. And yes, it just goes from strength to strength, to be honest.
Thank you, Hanif. Phil.
I'd just like to reinforce that 2 great reports. Just like to let the board know that we had a good discussion about when formal complaints are not upheld, how they're communicated to the patients, and try to understand how the complaint arose, and to address that rather than just informing the patient that the formal complaint had not been upheld. And I think that was well received, and I think there'll be some actions around that. So that was just from Quality Committee, that just so that you know that we were discussing that point.
Thanks, Phil, for that. That's a really important part of this as well, isn't it? That communication piece to people. But also, I was really pleased to sort of see again in the presentation that more issues are being resolved through an informal route as well, which shows again, I think, staff responding well when people do raise concerns that they actively engage at the earliest possible opportunity to see what could be resolved. I thought that was very positive in terms of the stats too. So that's so I'm glad to see that's happening. Okay, I haven't got anybody else. Mandy, thank you very much for those presentations. Our best wishes to everybody in the team who's working to work with our patients and service users and in this work, which is such an important part. And as Michelle said, very much linked to other discussions we're having around our culture, safety and supporting both our patients and our staff to do that work as well. Thank you.
Okay, thank you very much. Thank you. Goodbye.
Bye, Mandy. Have a great day.
Thank you.
Right, okay, moving on then to item 12, Kwame, Suicide and Self-Harm Strategic Plan Update.
So this is an update on the suicide plan that we had, which is from 2022 to 2025. I have presented some of these findings to the quality committee, so forgive me. Suicide is never a nice thing to talk about, and any of the numbers in the statistics, anybody who dies from suicide is a tragedy, and we do everything we can in a clinical setting to make sure it never happens. From the data, which has been, there's an outfit called the National Confidentiality Inquiry into Suicide, which is based in Manchester, led by Professor Appleby, and they collect data on every suicide that happened in the organization and brings out the themes and the lessons out of them. And I have used that as a way of informing the board and quality committee about what we're doing when we get these themes. We do speak to our clinical networks, we speak to our professional groups, and we incorporate that into our suicide plan so that it becomes a live and dynamic conversation rather than we have a suicide plan, it's for 3 years and nothing happens. So this is a kind of a dynamic conversation. The good news from this is that suicide is falling, and it's been falling for many years in England. However, there are still areas where we need to do more work, such as inpatient death, suicide when people have been discharged, as we have. The big thing that's happening in mental health, which is a good thing, is that care in the community has been the focus for many, many years. But unfortunately, people are dying in the community when they've been discharged. And therefore, one of the things that we have in the organization is the 3-day follow-up and the 7-day follow-up, which we do benchmark quite, and we take this very seriously, and we benchmark quite high. Then there is the theme around socioeconomic diversity, people who are going through divorce, people who are lonely. These are all the themes which makes people unfortunately commit suicide. The other areas which the theme coming out is suicide among young people. So under 25 has become an area which become a disturbing conversation in mental health. I was just listening to a talk this morning to the mental health group, mental health medical directors group, and in universities, almost 80% of young people are reporting mental health problems and have had suicide thought. 80%. I was mortified to hear that 80% of young people in university are saying they have a mental health problem. So we need to do something about it. Internet-related suicide is also become an issue, personality disorder. I think some of the theme, again, is all in a report, but gay, lesbian, and bisexual, the trend is going up again. That is supposed to be bring into our attention to have that incorporated into our suicide plan as we go forward. And then last but not the least, in terms of the messages, is the suicide by homicide for people who have been charged with homicide, and there is between the charged and going to court, a lot of them would commit suicide, and Professor Abubi wanted to bring that message up. So the summary of the clinical message is the focus on patients and carers, especially following the loss. We need to do more work on that, which we are. The steps by looking at community step down is an important focus. Financial support, pointing people out into different places to get help, is something that we need to focus on. We do young people and personality disorder, as well as people in the LGBTQ+ group. We have that all captured within our suicide plan with the 10 ways of improving safety, which I have talked about in various forums. The NHS England has recently released their 5-year cross-sectional strategy, which I was just about to put this to Jenny to add it when it came out. It came out on the 12th of September 2023, so it's hot off the press and the message is being digested, and I'll share that with the clinical group and the professional group. But most of the themes is similar to what Professor Abobi has talked about: physical health, financial difficulties, harmful gambling, use of substances. So those themes would be shared, and we use that as part of our way of helping patients so that unfortunately they don't commit suicide. And the other thing I was going to conclude, we're not doing that by ourselves. We do a lot of collaboration within the ICS. We do a lot of collaboration within place. I've attended the Humber Bridge board. As you know, Humber Bridge is one of the focus magnets for people committing suicide, and we try to support them. We have the Crisis Care Concordant, which we work with the police and work with our partners, and then we share the messages. And in addition to that, most of these information has been incorporated in our risk assessment and management and training, which every frontline clinician is on their ESR as a mandatory training for them to be able to get these messages and to support our patients and our carers. Thank you very much for listening to me. And Karen, see what if there are any comments and questions.
Thanks, Kwame. And we had a full discussion on this at a recent quality committee as well. Took place too. Mike.
Thank you, Kwame. Excellent report as usual. The Trust has put a lot of work into this for a considerable amount of time, and really practical interventions like moving from 7-day follow-up after discharge to 3-day follow-up. You mentioned the Humber Bridge board and the work with the taxi drivers about single journeys to the Humber Bridge. These are really good practical things, and the Crisis Concordat with the police that Michelle and Lynn have worked so hard on. But when we look at your report, we see that there's been a decrease in suicides during COVID. And I'm interested in that and the reasons, but not necessarily for this meeting. What I'm also interested in is, I know the sample size is small, but can we measure the effect of the work in the Humber region? Would we have expected more suicides without this work? Or is that just something that we can't actually measure, but we know it feels right?
Thanks, Mike. Kwame?
Yeah, a good question, Mike. And everywhere I've presented, whether it's professional group, clinical network, everybody's asked me that question about, can we tease out our data? If you can say anything that is good about suicide, is very, the numbers is 1 in 10,000, 1 in 100,000 per population. So you're talking about very small numbers. And Louise Appleby points out that we like to do regional trend and national trend. It is very, very difficult to bring it down to township or community trend. But what we do with our all the data is our trying to make sure that when we see an area, we do the learning to make sure that whatever we can do to prevent suicide within that area is improved. So that's the only thing we can do. But it's the doctors ask me all the time, can you tease out my CMHT data for me to see whether my suicide rate is going up? And I said, no, we can't do that. We can't bring it all the way down because 1 in 10,000, 100,000.
Okay. Thank you.
Thank you.
Dean.
Thank you, Caroline. Thank you, Kwame. And just, I suppose, an additional thank you just for the way that you presented that report both here and at Quality. It's great that we have sort of a compassionate, empathetic clinicians that can sort of see beyond the statistics into the tragedy. And I thought you expressed that really well. So thank you for the way that you did that, because they are important numbers, but important individuals as well. It was just an observation, really, just in terms of those latter issues about the risk areas, and just that opportunity to work across the system to, get joint endeavours around this work of suicide prevention. You talked about the police, but clearly across all those sort of interactions that we have with the health services, and just the extent to which we could do more, really, to get it on sort of ICB, ICS sort of agendas to be discussing, and get that sort of shared endeavour to reducing the numbers further. But thank you once again.
Thank you, Dean, on that. I think linked to that, I would say as well, is that thinking about the economic situations, that's often a trigger for people. There's obviously things like our job centre services in the area we serve. There's Citizens Advice and others who'll be working with people on debt advice as well. I mean, those are sort of obvious places. I'm sure there's relationships where information or signposting for people is an important part of this too. But yeah, thank you for that. Thank you, Kwame, for that update. Before we move on to infection prevention, can we just ratify the patient care experience 5-year forward plan and the patient care experience annual plan, which has gone through quality committee, but we have for approval, but we have to ratify it here. All those in favour of ratifying those two reports? Thank you very much. Great. Okay, we'll move on because we've got Debbie with us. Debbie Davis, our lead nurse infection prevention control, today for items 12 and 13, and then I suggest we'll take a break and come back to Hilary on the patient safety incident response after we've had a little break. So Debbie, sorry for keeping you waiting. Welcome, good to see you again. Over to you.
Yes, thank you very much. Yeah, as stated within the first report, it provides an overview of the key infection prevention and control work undertaken during the reporting period, and it highlights the progress against the trust infection prevention and control strategy. Both of the papers and the next paper have both been presented at the quality committee. I think it's fair to say that once again during this period, the COVID pandemic and the effects of this continued to take up a large amount of time and resources. But we were especially pleased that during this period, we were able to achieve full restoration of all of our planned programme activity, and also the regular face-to-face activities, which included visibility at the whole Pride event, undertaking of various promotional activities such as World Hand Hygiene and also World Sepsis Day. During the period of the year, overall organisation in the practice, RPC practice, was noted to be generally of a good to high standard. Where any results were lower than we expected, targeted work was completed with the areas concerned to improve this position. And this mainly was due to a change in leadership or, kind of the infection prevention and control link practitioner leaving or needing some additional support. We are not complacent, however, and work continues to sustain this position year out, and that has included the commencement of a full review of the Trust in Infection Prevention and Control educational programme, which has started just about the end of this report. We were pleased to say that all contractually agreed local and regional targets have been achieved, and where any individual cases of hospital onset infections were identified, the lessons where improvement was required following the incident was minimal, as can be seen within the report, particularly on table 1 on page 1 on the trust abortion cases of C. difficile, and also in the outbreak section on page 7. I'm pleased to report that no adverse outcomes were reported for any of the patients affected during any of these incidents. We are mindful, however, that whilst we've achieved all our mandatory surveillance targets, we are not as familiar with the burden of other infections across our mental health and community sites that aren't required from a mandatory perspective, but are equally as important to the patient and their ongoing care. We are pleased to report that we've availed ourselves of the opportunity to participate in a nationwide point prevalence survey, looking at the burden of hospital infection and antimicrobial prescribing practices within both of our settings, the community hospital setting and learning, kind of mental health and learning disabilities, to ensure that we've got appropriate measures in place. And we will also be able to benchmark ourselves against similar trusts. It's never been done before in any of our settings, which, I think it's been a really good opportunity, and that has started last week. Our particular challenges during this period has been the ageing estate, but work continues to address where feasible within the environmental and financial constraints that we have on site. Particular other challenges include ongoing water safety issues at Millview and Maister, but a massive team effort has been initiated, and we are looking at negative results in Millview. And they will be, I think we're at the end stage of that, and we're also hopeful that we'll be in the same position across at Maister, mirroring the work that's been done. We have actually got all mitigations in place to ensure the patient safety in each of these areas. And ventilation and hygiene facilities are still outstanding in some areas, the improvement work, but it has been raised, and ongoing improvement plans are in place. I mean, some of those are just the key key areas of focus that that we still need to do some work on. But do you want me to go on to the IPC plan and then questions, or?
Please, Debbie. Thank you.
Yes. The IPC plan has put has actually outlines the proposed key areas of improvement for the next 5 years. Mindful that in the delivery of the more ambitious elements of the plan, we should not lose grip and focus on the basic principles which are fundamental to both our staff and patient safety. And I think to this effect, we've aligned it to the the key areas within the trust strategy. But from my perspective, we need to maintain staff education. We need to look at what we're delivering, making sure it's fit for purpose for the future. We need to continue to engage with others. We've forged really good relationships with national teams and also local and regional teams, during the period of the pandemic. We need to maintain that. And I think the important element for me is the patient. We are mindful that we need to do some work, and we are we've got a member of the team working with Mandy and her team to make sure that the experiences and views of the patients during the pandemic are are captured and reflected, to ensure that we're prepared for any future goodness me pandemics or any other future influenza outbreaks, etc. And I think I think that probably is the incorporates all of the elements within the within the IPC plan. So that's just the report in a nutshell. Happy to take any comments or questions.
Thanks very much, Debbie. And I really like the way the 5-year plan has been put together. It's really clear against the strategic goals as well. Really clear about what you're trying to do and what you expect the outcome to be, which is really good to see. Very clear. Thank you, Hilary.
Thank you, Caroline. Just a few comments from me. Really good reports. These, Debbie, really show what the team and the wider team are doing to keep patients safe. I'm really pleased that 5-year plan has been co-produced. Can we get the co-production stamp on it so that everybody knows that we've done that with our patients? Just some general things at the minute around infection. COVID, the current variant, is highly transmissible, so I will encourage everybody that can access it to get their COVID vaccine, which should be coming out to people that fit the criteria soon. So please do that to protect communities and our patients. I have asked the infection control team to put together a briefing around mask wearing as we go into winter as part of our winter planning, just so we're really clear on what will tip us into mask wearing. We already know, obviously, on a site by site, depending upon COVID prevalence in our sites, but as an organisation as a whole, there may come a point where we need to go back into masks at some point. So that might be about increased sickness, prevalence, whatever, but just so that we've got something. So we're working on that at the moment as well. Really good to see in the annual report that notable improvement around COVID outbreaks from December 22. No new learning. So it looks like all the learning we've had has been embedded in practice, brought about change, and meant that we are reducing the outbreaks that we're getting, and staff aren't sort of breaching some of the infection control procedures from December 22, which is really good to see. But that's just what I wanted to say on the back of those reports. Thank you, Caroline.
Thanks very much, Hilary. Michelle.
Yeah, no, thanks. Just to build on Hilary's point, thanks for the work on this. And I agree with the Chair's comment. It's really, really good to see the 5-year plan set out so simple in relationship to our strategic objectives and what you're going to do. So I think that's really helpful. I was just going to say, we have put a session on for the board for COVID and flu vaccinations at our October strategic session. So please be aware that will be happening. But again, obviously for people listening, if we can strongly recommend, as Hilary said, that people are vaccinated for themselves and their communities. But just to say, when you look at the data on the enormous amount of work that you certainly have had to do, which you always do, but certainly you've had to do over the last couple of years with the pandemic, etc. And it is really a small team. So I would just like to commend the work, because we have noticed some significant differences around. And I think sometimes the reports just touch the surface of what actually goes on underneath, and I know what goes underneath as well. So I just commend the team, Hilary and Debbie and everybody, just to say thank you, well done, it's great, and carry on, keep it up.
Thank you.
I'd echo that as well, and just to share as well in the chat box, Phil has said that clearly, obviously, these two infection prevention control reports plans have gone to quality committee, and the view of the quality committee, there was a really high quality and they were really pleased to approve them. And our job now is to ratify both these plans. So in terms of the annual report, is the board happy to ratify? Yes, thank you. And in terms of the 5-year plan, which will get its co-production stamp on it, happy to ratify that as well. Brilliant. Thanks so much, Debbie. Sorry to have kept you waiting.
It's okay, no problem.
Great to see you, and best to the team. Okay, we are running a bit behind, so let's take a break now for about 5 minutes and come back and we'll resume. Thanks very much, everybody. Okay, welcome back to the board, and we are at item number 15, and Hilary's going to talk about the Patient Safety Incident Response Plan and policy. Hilary.
Thank you. I wouldn't normally bring a policy in full to the board, but this is such a significant shift. Obviously.
Hilary, you've frozen. Oops.
Can you hear me?
Hilary, you froze then. Could you just start again? You just said about the importance of bringing this to the board.
Okay, I'll keep my camera off for the minute while I'm talking, because I've noticed I've not got a good connection. So yeah, it's really important to bring it to the board. It's a fundamental shift in the way that we investigate patient safety incidents and learn from them, as I said earlier, from the Chief Exec's report. So that's why it's come today for the board to have a full look at it. But I know that in our strategy meeting in August, you had an opportunity to discuss this as well. So big shift. As you can see, the ICB have signed off our plan and policy, are very happy with our approach, and they are working with us and supporting us through the shift as well, because it does change the way commissioners oversee this work as well. Commissioners previously would have got all of our serious incident reports, would have reviewed them, signed them off, come back with comments, etc. That isn't there now for commissioners. Commissioners should be more about the learning and making sure the learning is shared across the system, and that as a lead provider, we need to be mindful of that as well in our role when we're working with our other providers. So I am working with our CPAC team as well on how we in our provider role also work with our providers to make sure that PSAF is properly embedded. Not a massive change in the way that we do our incidents. It's more about the language and the methodologies that's the massive change, because we'd already started to bring in a lot of the change in terms of looking at systems rather than root cause when we were doing our serious incidents. So we'd already brought that in. We'd already changed our frameworks. If an incident wasn't deemed to be a serious incident, we had significant event analysis, and we've just changed them now. They're going to be patient safety incident analysis using the swarm huddle methodology, which I know the board were appraised of all these different methodologies at the meeting in August. So some slight changes of things. We've got our patient safety partners in place, and they've been working with us as well. So we've got that patient safety, patient user view on everything that we've done, and it's been a lot of work up to now getting all these things produced, written, and consulting, lots of comms with staff to make sure that everybody's on board with this. We're looking to start 1st of October, providing the board approve our documents that we've got today, and I think, as we've already alluded to, that's when the work really starts, when we really make that shift and change. So I'm looking at a 6-month transition plan, which I'll be pulling together next week to move us through to the end of March in getting everything embedded that we need to get embedded, testing things out, and making sure that we don't drop the ball on anything, because it's just so important. And we will be double running for at least until December, because we've still got some SIs and SEAs in the system, as well as bringing in the new way of learning as well. So it's a big piece of work that's needed attention, a lot of attention from myself and my team, obviously, as we make the shift. So here for any comments, discussion, and hopefully seeking approval from the board so we can make that shift.
Thanks very much, Hilary. And of course, we discussed this at the strategic board meeting in August, and it's gone to quality committee as well. And just to say, I know she has received comments from Michelle and myself. Kate Baxendale, there was some fantastic positive comments from the ICS around her presentation that she gave recently, which I thought was, which was really good to hear that feedback too. So any other questions from the board? I'm glad to see the glossary in the plan as well, by the way, Hilary. Always like for lay people like me to have some of these things explained is always good to see, and I know there's going to be an easy to read version as well put together too. Any other questions or points colleagues would like to make? No. Okay, thank you very much, Hilary. Is everyone in favour of ratifying this policy? Thank you. Appreciate that. Thanks, Hilary. Thank you. Okay, moving on then to Pete, finance report.
Thanks, Caroline. So this is the finance report as at the end of August. As you can see from the report, at month 5, we haven't hit our financial target for the year to date, and we've actually recorded a £250,000 deficit position. I think this is the first time I've come to the board and reported that we're not actually on plan for probably 4 or 5 years. You know, you can see from the paper, the reason for the variance to plan is the increased property costs we've incurred at both Whitby and Malton, and those costs, those increases arose after we set our plan for the year, and have only arisen recently. We are in dialogue with the ICB at the moment about financial support for those pressures, because when we took on the contracts for those 2 areas, we had an agreement that any property pressures, recognising they were beyond our control, would be supported. At the moment, that support isn't forthcoming, so that is why we're pushing out our deficit, but we continue to negotiate that with the ICB. And very quickly, you'll see from the report, our cash position has dipped from where it was in previous months. Some of that is down to clearing our historic creditors with NHS Property Services, and we have got a cash recovery plan. We are starting to chase our debtors and our invoicing, and we are expecting cash to recover, and we will be taking a full cash flow forecast to the Finance Committee in October. And I'll stop there, take it as read, and happy to move to questions.
Thank you very much, Pete. Questions from colleagues or comments? Anybody? Dean.
Thank you, Caroline, and thank you, Peter. And I know you must feel for that, having to bring a report that's in an off-plan position, and thank you for laying out the reasons for that. I just wondered, Peter, just with the industrial action, whether there was any sort of implications there as well. I know that there's sort of adjustments being made for it, but whether we're in a position that we're receiving appropriate adjustments for example, loss of activity, and then I guess a different formula that we've got junior doctors and consultants on strike at the same time as well.
We are collecting the impact of the industrial action, Dean, and if I'm brutally honest, it's not material for us. As when I see the numbers, the acutes for us, it's not material, but we are expecting a level of support to flow, and Ian is leading that piece of work. Thank you.
Thank you, Dean. Can't see any other hands up. Okay, yeah. I mean, clearly this issue around Whitby and Malton, there's still discussions going on that, but contracts were, from what you've said in the report, contracts that were arranged have now been altered, which we couldn't have foreseen.
Absolutely. And, you know, if I'm brutally honest, it's disappointing that those contractual commitments haven't been honoured by the ICB, because we went into those arrangements in good faith.
Is there anything more we could do as a board, Pete?
If we don't make any traction in the next couple of months, Caroline, maybe a process of escalation, chief exec to chief exec, chair to chair. But at the moment, I'm hoping I can resolve it in the finance community.
Okay. All right. Thanks very much. Okay. Let's move on to the performance report then.
Yep. So I'll be very brief on the introduction, so we've got more time for questions. So again, this is the performance report as at the end of August. As you can see from the report, you know, our performance is broadly consistent with what we've brought to the board in previous months, and we've got the detailed appendix with the commentary on waiting times. We've also included the 3 new indicators in this month's report that we agreed at the strategic board session earlier this year. So we've now got the data flowing for those. I guess the one thing I would bring to the board's attention, and we had a conversation about this at exec on Monday, is we have seen an improvement in our neuro trajectories, and that's as a result of the non-recurrent investment we agreed as a trust this financial year. Obviously, there's a recurrent pressure in the neuro pathway, and depending on where we get to in the planning round for 24-25, if recurrent funding isn't secured, there's a real possibility that we'll see a deterioration in that performance. So I think it's important the board are aware of that, and obviously we'll keep the board briefed as we go through the planning round. I'll stop there, and I'm happy to take questions.
Thanks, Pete. Questions from colleagues? Anything to the performance report? Nope. Okay. I presume the appropriate board subcommittee might look into that issue around the non-recurrent spending, and maybe in a bit more depth when it's an appropriate time to then bring back to board, maybe.
Yeah, I think it would probably go to quality and finance.
Okay. All right. Okay, thanks very much. Pete, moving on then, we have the risk register update with Oliver.
Hi, good morning, everybody.
Morning, Oliver. Good to see you.
Okay. Am I okay to start, Caroline?
Yeah,
Sorry.
absolutely.
Yeah, thank you. Cheers. Okay, thanks very much. So the risk register report obviously details the current position primarily around the trust-wide risk register, which is essentially the risks that we have recorded, which have a current score of 15 or above, although essentially the red-rated risks for the organisation. There are currently 5 risks included on that document that were discussed at EMT and obviously have been through relevant governance forums through both divisional governance arrangements, but also the operational delivery group. The main sort of changes for this month's position when compared to last report to the board in July, we've got one additional risk that has been escalated via ODG, discussed at EMT, and is now included, and that's risk LDC 82, which is the risk around increased demand for ADHD medication and associated waiting lists linked to that within the service. So obviously that was discussed via ODG. It's been escalated as obviously quite a considerable risk for us. Continues to obviously be monitored via the divisional governance arrangements and the operational delivery group itself. So obviously that's been included for this quarter's position. 2 risks have been closed since last reported to Trust Board in July, or essentially closed from the trust-wide risk register, I should say. WF37, which was the risk around the GP vacancies within primary care, has been rescoped in terms of its score. Now sits with a current rating of 12, so it's below the threshold for inclusion, but does still remain on the Workforce and OD risk register, and it is reported into the Workforce and OD committee as well. Obviously, we continue to review any issues in line with staffing, and particularly the obviously GP position via ODG as well. So it is being monitored, and if there is a substantial change to that position that does warrant escalation and obviously re-inclusion on the trust-wide risk register, that can then be actioned. But as it currently stands, obviously below that threshold for inclusion today. And then Ops 15, which was the risk around the system pressures, and particularly the number of delayed transfers of cares that we were seeing, has also been reduced to a current score of 12. So I think they both still pose risks for the organisation. They are obviously being monitored via alternative arrangements as opposed to EMT and board. But obviously we are primed that should the situation change, should there be any sort of deterioration in those risks, we can re-escalate as required. So just worthwhile noting that those 2 have now dropped off and kind of go along with that governance process that underpin the trust-wide risk register review arrangements. Only other points to note in terms of highlights, slight reduction in terms of total number of risks from July's position. So 132 risks total for the trust in July. That's come down to 129. That is not just the closure of 3 risks. There has been some additional risks and risks closed off, obviously, to bring us to that composite figure. But again, obviously, all of the risks go through appropriate governance arrangements, and we're quite satisfied the processes are working effectively in terms of escalation and de-escalation of the risks as well. So those are the key points just wanted to highlight for the purposes of today. Happy to take any feedback, any questions at this point in time.
Thanks, Oliver. Any questions or feedback, Francis?
Just a minor one. Great report, Oliver, as ever, hugely detailed. On the key strategic risks under the what additional actions need to be completed, one has gone past its date for completion, one's due for completion in a day or 2, and there's a couple coming up shortly. So will we get an update on those and see what effect, if anything, they've had on the risks?
Absolutely. We'll be reviewing the timescales. I think obviously just have that discussion as well. So I can include an update obviously next time around if there has been the impact, but obviously there'll be a full review of the actions in line with the next sort of next few weeks in terms of review schedule. So more than happy to get that incorporated and that considered as part of the next update.
Thank you. Thanks, Francis. Okay, I can't see anybody else's hand up. If we move on to the board assurance framework.
Thank you. So the board assurance framework obviously continues in the newly established template that we implemented in Q1 following the development session that took place in April. In terms of obviously the position for the quarter, not a great deal of movement in terms of some of the indicators, but just to highlight, a lot of those are 6 monthly sort of timescale related indicators. So we might not have seen a great deal of movement from Q1 into Q2. I expect to see some further movement in Q3 as obviously some of those work streams and elements progress. But obviously, you know, it does represent quite a shift overall. And obviously, again, I mean, don't go into too much detail. Obviously, quite a lot of information included on the document, but obviously, again, happy to take any feedback or questions in regards to the BAF. I think the new template seems to be working really well. Obviously, we'll continue to develop that as we go through the year, and obviously as we come into next year and we revamp the risk management strategy for the next 4-year period, any further refinements will be considered as well and obviously discussed via EMT. But again, happy to take any feedback, any comments, anything that we need to consider going into Q3.
Thanks very much, Oliver. Any comments, feedback? Everyone? No, it's been a good exercise to discuss how this is put together, and it's as you say, we'll see how it works in practice in the months ahead. But you know, it's been a product of a really good discussion and engagement with others as well. Thanks, Oliver. Okay, Michelle, sorry.
You know, I've really just been put I'd like to thank colleagues on the table as well, and particularly chairs of the assurance committees, because they've been really helpful in guiding this and developing it. As you say, well, it's organic, isn't it? Well, no doubt we'll continue to change it. But obviously, thanks to Oliver as always, but also thanks to colleagues on the table who've offered really good suggestions, and hopefully it's meeting our needs now of what we need. But as I say, we'll keep it going. But again, thanks to everybody for that, because it's been a collective effort, I think, to get it to this level.
Definitely. Thank you. Thanks, Oliver. Have a
Thank
good
you very
rest
much,
of the
everybody.
day and week.
Thank you.
Thank you. Bye. Okay, we'll move on to the next item, which is compliance with the new provider license. And we've got Pete, I think. Yes. And Stella.
Yeah, I'll take it and then we can go straight to questions. So obviously with the new provider license, there's no need to publish an annual declaration like we did with the old license, but we had a conversation at Executive Board time out from memory that we thought still producing the evidence and review it as a board was good practice. Myself and Stella have reviewed the license, pulled the evidence together. The report has been to EMT. It's brought to board for board to consider it and perhaps provide other bits that we may have missed. The plan would then be to take it to governors and then bring this as part of the suite of annual reports next year. Don't know if there's anything you'd want to add, Stella.
No, I think you've said it succinctly, Pete.
I do my best.
Great. Okay. Any questions or comments on this paper? No? That's great. Okay. Thank you for that, Pete and Stella. Moving on to the next one, which we need to approve, I understand. Kwame, the Quality Assurance to Responsible Officers and Revalidation paper.
So in line with the good medical practice and the GMC requirement for all doctors to have appraisals and revalidation, there's a yearly requirement for the GMC, the NHS England, to be assured that the board has made sight of the fact that we are providing quality revalidation and assure and appraisals for all senior doctors within the organization. Quickly, mainly to say that this report will be shared with the Tier 2 responsible officer in NHS England, and the board to note that we are compliance with the requirement as a designated body. And the Chief Executive, Michelle, would have to sign the report for the report to go up. In terms of positive assurance, we continue to meet as an appraiser team to make sure that we are meeting all our requirements. We are also trying to encourage more doctors to become appraisers so that the quality would be improved. There isn't any concern for board to note, but simply a retention of existing actions which are mainly related to maintaining good standard. There is a set of questions which the GMC and NHS England require, which we have answered thoroughly, which will be part of the process to go up. And I want to, it's more for noting for the board, my understanding. But if the board, which if there's any comments from colleagues, I'll be happy to pick up comments or questions.
Any comments, Dean?
Thank you, Kwame, for the report on responsible officers, and happy to approve on the basis here. But I wonder if you could just say something, given this is about assuring ourselves about the the fit to practice of doctors, just something about the responsible officer for agency doctors and how we get assurance on that.
So with agency doctors, all agency doctors have their own responsible officers. What we have put in place is that when they join our organization, we have a link between our responsible officer and their responsible officer to get a summary of their last appraisals, and any ongoing appraisal is then a summary is sent to us. That's the assurance we put in place to make sure that there's a link. And then when we also see any information, other complaint, we do send it to their responsible officer to make sure that there's a link and nobody falls through the net. Thank you.
Happy with that, Dean? Great. Okay, thank you. Any other questions? Okay. My indication is that we should approve this. You're suggesting it should just be noted.
No. No, I think, sorry, Caroline, that was my hand. I think the board need to approve it for me to sign it.
Yes, what I thought. That's what I thought. I was going to basically go for the safety option. We'll approve it, and if it, I will later on, if that's not the case, it doesn't really matter. But I think it's really important we just get that right. So unless there's no other questions, comments, so put it to the board. Are you happy to approve this paper and the policy behind it? Thank you very much. Thank you. That is approved. Okay, moving on then, we go to the operating pressure escalation level, and this is Claire picking up this one, item 22.
Yes, this is just a very short paper, Caroline, explaining what the role of the System Coordination Centre is, and it details how we intend to work with that within the system in order to sort of support the EPR processes. We're currently in the process of waiting for the an agreed OPAL framework that we're looking at from a mental health point of view, so that we can review that against our own current OPAL reporting methods, with the intention for us to, as a system, compare apples with apples in terms of where we are in terms of our pressures. As the paper details, the excuse me, SCC will have the overarching viewpoint of sort of pressures across the system. So the intention is that as pressures occur, they're going to be able to divert resources or advise you where support could come from. But as it says, that we're waiting for that OPAL framework in order to sort of kickstart that piece of work. But the paper just gives that overview and detail of what the SCC is about and what its function is.
Okay, thanks very much, Claire. Any questions or comments to Claire on that? Okay, can I Phil.
Yeah, just a really brief one. Obviously OPAL also involves primary care as well.
It does, yes.
And primary care have been confused for many years about, even if you fill these things in, that does it have any impact? But I think they're realising that it's quite important sign of distress, and if the system's likely to support them, then they need to report accurately. So I think they're finally getting there, but just it wasn't in there. I just wanted to reinforce that it also involves primary care.
It does. I mean, this is particularly around mental health, but from our point of view, we absolutely do report our position in terms of from a primary care point of view. And it's a case of the system starting to work more effectively to actually look at what those pressures are. So, yeah, absolutely.
And I presume on that one, Claire, because we are a multi-service organisation, and therefore some of this reporting is not a new, is basically part of the core business that we do anyway. Yes. The fact that we have got 3 primary care practices within our service area, we're able to provide that sort of, I suppose, support for those practices as well to do this, which might be more difficult for some of the other primary practices, or not difficult, or not as usual. Exactly. In other parts of the system.
Yeah, I agree. And I think in terms of what we've done is we've made sure that in our latest SITREP reporting, we've got a real breakdown so we can see exactly where the pressures are. So we've got more detail. So it allows us to understand ourselves where we can help out, in terms of where those pressures sit, but also provides that to the system, the broader system as well as. So, yes.
Thanks, Claire. Okay, we'll move on then to item 23, the patient-led assessment of the care environment. Pete, thanks, Claire.
Lovely, thanks, Caroline. So I'll be brief. This report summarises the place scores from the 2022 place assessments. The scores are broadly similar with what we've done in previous years, even though the assessment framework has changed, and we tend to be there or thereabouts consistent with the national average. What I would highlight is we have got 200,000 in this year's capital programme to implement the action plans arising from last year's place surveys, and we are just in the process of starting the 2023 place assessments. So I'll stop there, take the report as read, and happy to take any questions.
Okay, Michelle and I actually we're in up in Scarborough next week. I think we've got a visit to Malton actually next week planned, haven't we, Michelle? Is there anything particular you might want to add in relation to Malton and some of the issues there?
So the two issues we had at Moulton, one was cleanliness, and that's been addressed now through our contract with York LLP, and the standards of cleanliness have improved. So I'd welcome any feedback on your thoughts on the standard of cleanliness when you visit the ward. And obviously there are still some challenges we have with the environment up there, and we continue to pick them up through the contract, but getting staff's views on that, Caroline and Michelle, would be really helpful to feedback.
Okay, thanks for that. Any other questions on this report? Nope. Okay, thank you very much, Pete. We move on then to the staff survey progress report. Karen.
Thank you. So in brief, I think this report is a testament to the ongoing conversation that the staff survey is in our organisation. And I think also how important it is not only to understand staff experience, but as a recruitment and retention tool. So I know that this was discussed in terms of 2023 planning at the Strategic Board Development Session back in August. But what this report gives you is that kind of full overview of the position as we came out of the 2022 survey. And you'll see at one of the appendices there, the question by question breakdown. But that is just a recap. And what we want to do as part of this report is provide that assurance that we have taken action in response to what the survey told us in 2022. So I think you'll see from section 3, the broad organisational actions, and they are largely reflective of a number of the conversations that we've had about addressing culture through the Respect campaign and things like that you've seen periodically over a period of time. And equally at section 4, what you can see there is a bit of a snapshot of the bespoke actions that have been taken and continue to be taken at a local level in terms to address those specific localised concerns that maybe arose out of the survey in 2022. And I guess this is really timely in terms of coming to board today, given that the 2023 survey will land in inboxes next week. So the paper does outline the trust incentive scheme for 2023 as well, which is really important for us to see whether that is something that will enable us to drive up our completion rates. So I'm happy to take any questions.
Thanks, Karen. Any questions to Karen or comments? No? Okay, we had a good discussion in August on this as well, didn't we? So yeah, so the survey window's opening on Monday the 2nd of October for 8 weeks. So yeah, it would be good to, obviously we'll be kept informed presumably during that time as to how it's going and how it's progressing. But yeah, thank you. Okay.
Thank you.
All right, thanks very much. We move on then to, excuse me, let me find my bit of paper. We we've got 25, 26, 27. We've got John with us, haven't we? Is John here?
Hello, yes.
Hi, John. We've got various schemes around disability equality, race equality, and the equality diversion inclusion report, diversity and inclusion report. It says diversion on the Auden paper. I don't think it should be that. It should be diversity. But anyway, over to you, John.
Thank you. Hello, all. I will try to be as succinct as I possibly can. I could talk all day about these reports. Okay, so I'll take the reports as read and give you some sort of headlines and key successes with the reports. So first, the key report that we deliver is the Equality, Diversity and Inclusion Annual Report. And that is a report that brings together all the actions that are arising from our analysis of the staff survey, the RES, the DES and the gender pay gap. And the key thing to be aware of this year is that we're above average for all the workforce disability equality standard metrics and for 8 out of 9 of the workforce race equality standard metrics. Our gender pay gap is 13.2%, which is below the national average for the sector. But a key success is the DES this year, the Workforce Disability Equality Standard, where we're 29th out of 212 trusts. That puts us in the top 14%. And 5 out of those 10 metrics are in the top 10% of the country. And one of those metrics is 3rd in the country. So something to celebrate there. Representation of staff with a disability and those from a more diverse background continue to improve year on year. We drew particular praise, in fact, from the National Disability Team from NHS England, because we have a disability representation of 8.5%, and this compares to 4.5% nationally. And they did ask us what our secret was, and we shared with them sort of how we went about improving our representation, and they're sharing that out wider as best practice, which is excellent. Our staff survey results for equality and diversity are 8.4, and they continue to be above national average, just short of the best figure, which is 8.7. But our annual report led us to some areas of focus, which were looking at improving diversity in senior roles. And when I talk about the res and the des in a moment, you'll see where that's targeted. We'll launch the Respect and Dignity campaign to address bullying and harassment, which I know has been discussed quite widely now across the organisation. We're in the final stages of getting our posters printed and looking for those to be delivered around mid-October to every site in the trust. Working to gain accreditation with the NHS Rainbow Badge Scheme, moving towards being a disability confident leader, continue to drive the process to reduce the number of unspecified entries in our staff records. And this is what helps us improve our declaration rates and our quality data, which I mentioned earlier. We have gone up. Back in 2019, our disability representation was less than 3%. It's now 8.5%. It's not that we're hiring more people with a disability, it's that people are more comfortable telling us they have a disability, which means more people are accessing reasonable adjustments and things like that, which again is something to be celebrated. We're also going to have an ongoing analysis of our EDI data, an EDI deep dive around recruitment. This will be twice a year, looking at areas of underrepresentation, and it goes into area level where we can identify where particular areas in the trust are underrepresented, and we can our HR business partners can work with those areas to target in those advertisements for roles, particularly band 7 and above. Moving on to the res, the headline figure there is that in 8 of the 9 metrics, the trust is above national averages, which again is the first time we've been above national average for 8 out of 9 since before 2019. The key thing here is the shortlisting of ratio to appointment of ethnically diverse candidates compared to white candidates is 0.78, which is better than equality. 1 is equality, which means there is no disadvantage. So we can say that with some confidence that candidates from diverse backgrounds are not disadvantaged by our recruitment processes. And that is likely to see us in the top 10% of the trusts when the national res team come back with their overall analysis. One thing to note, that representation of staff from diverse backgrounds has improved year on year and is now just over 6% compared to just under 5% regionally. But there was a low level of respondents with just 66 staff from diverse backgrounds, that's 30%, completing the staff survey. So a bit of work for me to do around trying to share messages within the staff survey messages about how staff with a disability or staff from ethnically diverse backgrounds can contribute by engaging the staff survey towards the res and towards the des, and how important that is. But that gives us a focus on representation of candidates from diverse backgrounds in band 7 and above in non-clinical roles, but also staff experiencing harassment, bullying and abuse from managers, which is being addressed through our Respect campaign. Onto the des, the headline there, as I mentioned previously, and it's a real celebratory piece, is that the trust is 29th place nationally out of 212 trusts. As I say, that is the top 14%. Half of our metrics are in the top 10, and one of them was 3rd in the country. So again, we've improved representation of staff with a disability year on year to 8.5%. But it's worth bearing in mind that regionally, the figure is 1 in 5, so 20%. So there's still work for us to do to continue to improve our data to be more representative of the region. An example of this is we had up to 370 respondents of the staff survey disability questions, questions that relate to the Workforce Disability Equality Standard. But ESR suggests we have 284 staff with a disability or long-term condition. As such, there are staff out there who have not declared a disability and perhaps may not be getting the reasonable adjustments from the workplace they deserve. So some work for us to do again to make sure that we reach out and communicate that message so we continue to really drive up the accuracy of our equality data. But that report led to some areas of focus, particularly around representation of disability in senior leaders and bands 8B and above, and staff experiencing bullying, harassment or abuse from patients and service users. Again, our Respect and Report It campaign will be addressing that. So I'll stop speaking now because that was a lot of information in a very short period of time. Is there any questions?
Thanks very much, John. Some really positive outcomes we're seeing there. Really good to hear. Karen.
It was just really to extend some thanks to John, because there's an incredible amount of work there, and to have covered the amount of information that you have there so succinctly, very well done, because I think there's a lot to celebrate in there. There's still a lot of work to do, and I think we acknowledge that within the reports, but lots of activity and a lot of commitment across the organisation, particularly from ops colleagues as well, to drive forward the agenda. So just a massive thank you from me.
Thanks, Karen. Any other comments? I've got Michelle.
Yeah, thanks, John. It's good to have you back, and some great comments in the chat box. And there was a lot of information there you covered very quickly and very succinctly and very well. So thank you for that. And I was just wondering, there are some really good startling statistics in here about how well we're performing, and I think that's good. We need to continue that. There is work to do. So I just thought about that extra communication, and maybe Karen and John, you can have a think about how we do that across the organisation, especially as we're leading into the staff survey. I think that might be helpful. And I suppose people know I'm going to say this, and apologies, I maybe should have picked it for the exec, but there is such good work here. I was just wondering if we should do a little, because I'm quite obsessed with videos, so we've probably seen today a little video of some of the work that we're doing. John, that means you're getting on camera again in relationship to explaining some of this with some of the graphics in the background. Just a thought, because there's a lot of information and detail in here. So if we could maybe pick out a few things, but I'm not saying we should do it, by the way. I'll just leave it with you with a thought and a reflection, but great work, and it's really good to see the progress, and I look forward to the continuation of the work that we're doing. And I think obviously we keep mentioning our culture and being humble, but I think also the work that we're doing in relationship to report it as well will really be helpful. But just how we send those communication messages out is important for me.
Yeah. I absolutely agree. I believe a good news story that relates to this would be great, because I think sometimes we talk about a lot what we're not doing right. We don't always celebrate our successes as equally across the board. And I think sometimes as well, it's an opportunity to talk to our staff about what we are getting things right, because often we'll hear when we're not. And, there's a good counterbalance here to be able to sit and say, actually, here's a great success that we are doing. We're not resting on our laurels, though. We are going to, work this. We want to drive all gaps down and things like that. But I absolutely agree. And I can speak to comms about a video production. And if I'm honest, I don't mind being in front of camera.
No, you need to be on it, John. But I think it's that balance. It's not saying that we're absolutely fine and we're going to sit back on our laurels, and but it's about that balance, really. That yes, we've got work to do, we're on a journey, etc. But actually, these are some of the things that we are doing pretty good at. But keep and maintain that as well. I look forward to seeing it. Then I'll leave it with you and Karen.
That's great. Thank you, Michelle. I tell you, I was trying to write down those ones you picked out then, John, in your rapid presentation there, which was great. I just wondered if I could ask one thing. Maybe if there were about half a dozen there, which I thought really stood out. If we could just maybe get that on a note to all of us at board, so we've got I can pick it up and use it whenever I need to. That'd be really helpful.
I can forward you my script.
That'd be perfect. Thank you so much.
Yeah, a brief summary with all those details on.
That would be really great. I think we'd all, certainly I would, I think we'd all welcome that. We can use it when we go out to meetings externally as well, not just internally too. Great. Okay. Unless there's any other questions for John, we've got to ratify each of these reports. So firstly, let's do the Workforce Disability Equality Scheme annual report. Are we happy to ratify that? Yes, thumbs up. Thank you very much. The Workforce Race Equality Scheme annual report, happy to ratify that. Yeah. And the Equality, Diversity and Inclusion annual report, happy to ratify that. And there's a lot of work underway, and we'll be hearing more about that as the year proceeds. Thank you, John, and welcome back. Good to have you back with us. Right, okay, we move on now back to Claire for the Trust's winter plan. We had a bit of this in the Chief Exec's report, but here's a little bit more of an in-depth brief from Claire. Claire.
Thank you. So as the report says, this provides an overview of our planning and initiatives that we have set against the sort of system objectives heading into winter 23-24. The report, and there's plenty of detail in there, considers how we're preparing for the ongoing levels of demand across our mental health acute pathways. And it gives details of our ED streaming initiative, the work that we're doing in relation to out of area patients and delayed transfers in care. if there is any funding forthcoming this year, which we're hopeful there will be, we're looking at step up and step down beds so that we can maintain patient flow. And we've already embarked on a piece of work with NHS 111. We're a pilot site for calls going through to NHS 1 being diverted into our own crisis lines, and that's recently just began. And we'll continue to work with Yorkshire Ambulance Service in relation to the mental health response vehicle, which has been in place for the past few winters, I think. From a children and young people perspective, our focus, and we've talked about it earlier, is on reducing those long waits in CAMHS and neurodiversity and trying to keep on top of that despite the increasing significant increase in referrals that we're receiving. And also from an LD point of view, we aim to sort of increase our in-reach support into the acute services to make sure that those patients get the support that they need at a difficult time. We've already heard today about the vaccination programme, which is key to make sure that we have a healthy workforce, as healthy as we can have going into winter, with joint clinics due to start next week for flu and COVID. And I think the communications is due to come out about that. We're working closely with recruitment colleagues to make sure that vacant posts are filled and to increase our bank availability, just to make sure we've got that flexibility over the winter months to fill any gaps we've got with from a staffing point of view. I've already touched on the industrial action. That continues and it is a risk to us, but we can expect to continue to manage this through the winter months. And so that's just an added aspect that we've got to take into consideration during a challenging time. We do have the adverse weather plan, sorry, and that has been refreshed, and the focus remains on the agile working and the benefits that are derived from that. But also we have the four-wheel drive vehicles available for those staff that are out in the field. So it's a case of we've got that sort of versatility. We do expect winter to be another challenging period. We do think we've got a clear approach in terms of some of the initiatives that we've got in place, and we've learned from what we've done previously. But we're hoping to anticipate those challenges going forward, and working with the system, as I've said previously, to make sure that we work in collaboration and provide support across all areas where we can, and to receive it if we need to. So I think that's just a quick summary of the sort of planning, and behind all of this there is a more detailed action plan at a divisional level to actually for us to work through.
Okay, thank you very much, Claire. Any questions or feedback to Claire? Michelle?
It's just an addition really, because obviously it's a detailed report. I'll throw it out to questions, but just to say this links into the system as well. I've alluded to, but we've done a big piece of work both from a mental health point of view, and obviously we're looking at that now for community and local authorities. So this is a part of that jigsaw to try and get the system, working better together over the winter period, and really maximising the resource that we've got and the capacity that we've got across. So it is a cog in that. Yeah. Thank you.
Thank you, Michelle. I had a sort of question really around that. I mean, I know that is happening, and we can see obviously the discussion that's happening across the system in the report. Are you, Claire, or maybe even Michelle, are you given, since the new ICS was set up and the board, and it's still growing, are we seeing any qualitative differences in terms of the system working together for winter planning that's different from what went before, that you could sort of highlight maybe for us?
Some aspects, I think, in terms of there's lots of local resilience forums that we attend, so we're very much an active part of the system. I think in terms of there is a real focus on the acute services and the flow. So actually and the fact, I suppose the point being is the fact that we received the money for the ED streaming was a real positive move. And I think that was from sort of partnership working in the system working together. But I think in terms of it's certainly starting to form now. And I think with we mentioned about the OPAL reporting and the FCC having that oversight, I think that's going to be really key in terms of actually how do we respond together, which I think we've tried to do previously, and hopefully that will mature more with the advent of that. So that's hopeful.
Thank you. Thank you. Okay, I can't see any other hands up, so thank you for that, Claire. And we move on to item 29, and we have Dr. Kadri with us. Where is Mo there? We're a bit early, actually. If he's not arrived, we can come back.
No, he's here.
Is he here? Hi. Hiya. Sorry about that. I've got lots of faces on my screen. Sorry about that. Okay, over to you then, Doctor.
So I'm coming up to 3 years in the Guardian safe working role, and the report shows no changes in trends, which is helpful. So we've not seen any exceptions being raised helpfully in the education aspect. So all trainees are attending training and teaching, so which is good. We still have low numbers of exceptions, so there's no change there. Lots of work has been done in the background with medical workforce alongside the trainees and the junior doctor committee to try and streamline the on-call work. So mainly the exceptions are due to the busyness on an on-call period. We're currently doing some work at the moment in terms of getting the junior doctors to engage better with the on-call monitoring, so we can better improve the, I suppose, the spread of the on-call work. So we met recently with the junior doctor committee as well as medical workforce. We're trying to get the trainees on board with that, and we're hoping that will contribute to better and safe working on the on-call where the exceptions are being raised. There were a couple of glitches with the Allocate software system, and that's been well documented. And Lisa Arnold from Medical Workforce is working with Allocate to be able to bring those issues much quicker so we can troubleshoot those issues. So that's being looked at. And the other only odd thing that was occurring, and that was looked at the consultant meeting, which was what to do when junior doctors were calling in sick on the day, but that was looked at, and there's a plan in place now, because that was lending itself to some stress on the person that was on call on that particular day, but that's now being shared across the consultant group as well, so that's quicker triaged, so again contributing to better safe working practices.
Good. Thank you very much. And just generally, I mean, obviously the junior doctors feel confident about raising issues of concern.
Yes, so there's been a new change of JDC chair, and I met with them, and they're very candid about what their issues are, and we want to create this culture of transparency and openness, and they're very open about where their struggles are. And I think the most recent meeting we had was very helpful. There is a reluctance from junior doctors, I suppose, to raise issues, but I think that's not the case here. I think they're quite happy to bring that up. Dr. Fofi is also very open and, approachable, so I think that really helps. So I think we've got a really good relationship with the junior doctors. I will ask them very politely if they want me to attend. Often they say we'd rather you don't attend because we can open more freely. And they've also got Lisa Arnold, who comes in, and she's offered to look at the rota, look at the working practices. So we've got a very sharing an open approach, which helps because the junior doctors can tell us directly where the struggles are, and we can respond very quickly to see if we can change anything. So like I said, at the moment, there's some work being done on the engagement with monitoring, and hopefully we can improve the rota moving forward even more.
Yeah. And I suppose the other side of that is also that their seniors, the consultants, are also culturally open to encouraging and sort of looking for evidence where there are problems maybe emerging that they're not hearing.
Absolutely. And we had this very open meeting. Dr. Fofi was there. The consultants were discussing this openly and helpfully wanting to contribute, especially on weekends, and seeing where they can respond quickly. And the Freedom to Speak Up Guardians also keen to engage with the Junior Doctor Committee. I meet with the Freedom to Speak Up Guardian regularly to see if there are any issues very early on, so we can discuss them openly. So I think we've got a very proactive approach. We don't want to see the problems and then respond. We want to try and be preemptive with that, and that's working very well. And I think empowering the junior doctors to be able to speak with us has been, I think, paramount in that.
Thank you, Mo. And I know you went to the Workforce Committee as well and had the discussion there too. So thank you, and that's really reassuring to know that our junior doctors feel comfortable speaking up, and the senior management over them is also providing that two-way encouragement. I think really important. Thank you. Any other questions from colleagues? Kwame.
Yeah, No, thank you, Mo, for all the work you do. And also for the board, we do get also the triangulation from our GMC survey and junior doctor survey, which comes through. It's supposed to be anonymous, but the juniors do, with the feedback that comes, it's usually quite good. So apart from the face-to-face meetings and encouragement, they also do have ability to give feedback through the GMC survey, which we always benchmark quite well. Thank you. Thank you, Mo, for all your work.
Thanks, Kwame. Michelle?
No, thanks. I can't believe it's been 3 years either. I mean, it's just such a long time.
Yeah.
But seriously, thank you for all that we're doing. And it's just a thing that play. I know that we do this, but just to ensure that we triangulate this report with our other data as well, and what other feedback that we're getting, because it's that triangulation that's important as well. But it's good to see there has been some progress as well, but it's good to see the work that's happening as well, especially on things like the freedom to speak up as well, because I know we're going to do more in relationship to that over the next few months. But thank you, great stuff.
Great, thank you, Doctor. Have a great day. Have a great week. Thank you very much. Oh, sorry, Hilary, you had your hand up.
Yeah. Sorry, it was just while we're on the subject, Hull York Medical School have asked me to go and speak to them about patient safety in the NHS. I think that's really positive, because it's like really working upstream. So obviously I'll get all these key messages about speaking up and everything into that session that I do with them. So I just thought the board would be interested to know that I've been approached to do that.
Great, thank you for that, Hilary. Brilliant. Okay, thanks very much. We'll move on now to number 30. We've got the Quality Committee Assurance Report. Phil.
Yeah, I can say that this meeting was excellently chaired, because Dean kindly chaired this meeting for me. I was on the call, but I was away and was worried that my internet would be very good, but it was better than it ever is, actually. So it was a really good meeting. We got some really good positive assurances, evidence of proactive work. So, for example, there's a new procedure in place for examining deaths and certifying deaths, and we got good proactive input that meetings are already taking place with York and Scarborough medical examiner, and the meetings were planned with Hull and East Riding, and then also that the organisation was responding to issues. So there was a deep dive into all CMHT complaints and with an action plan. So that was a good example of both proactive work and responding to issues. And we got lots of positive assurances. And I can't believe it. It's Quality Committee again tomorrow when we're running through a lot of the annual reports.
Thanks very much, Phil. Any questions or feedback? Congratulations to Dean. Sounded like an episode of Stars in Their Eyes tonight. Dean Royals is Dr. Philip Wernershaw. Okay, I can't see any hands up. Thank you very much. Moving on then to the Mental Health Legislation Committee Assurance Report. Mike?
It's another Stars in Your Eyes one, I'm afraid. I did attend the meeting, but due to issues with the computers and eyesight and things, Dean chaired it really, really well. So I was there. The main thing I'd like to highlight, if I can, and I'll pass over to Dean, is to say about the correlation or corroboration of what I said earlier about RRI closed cultures, and you can see the focus of the committee on that. Detention benchmarking work in progress, the seclusion report being done in a timely matter, and issues around the consent to treatment being resolved largely. So good meeting. It was nice to sit on the outside and observe it, because I felt it was very good natured. It's one where we do have external partners with us, and it was really nice to have a meeting that was a conversation as opposed to just going through the agendas. So over to Dean if there's any questions.
The only thing I would add, Mike, is I agree with you in terms of this committee, and by the way, it works that way because of your excellent chairing previously that's established it that way. But I just thought there was a really good discussion on the the DOLs and the sort of timely best interest assessments, and sort of really getting to grips with how we might do that. And just an escalation there where we'd said, is that something that perhaps needs to go on the risk register? And the executive team will look at that at an appropriate point. But it's as you say, really good meeting with stakeholders as well. Thank you.
Thanks, Dean. Any questions or comments? No, thank you. It's very, all these reports are really clear about what's been discussed and further work that's being undertaken. Thanks, Mike. Thanks, Dean, on that. Audit Committee Assurance Report, and Pete's doing this. Stuart's away on leave. Pete.
Yep, so Dean didn't actually chair this one, Stuart did, and I'll just do the assurance on his behalf. So we had a really positive audit committee meeting. It was really good to see the final 6 audit reports for the 22-23 plan all provided high or significant assurance. Really good feedback on audit recommendations, and we're often held as an exemplar with our peers in terms of where we are on follow-up recommendations. And good to see progress being made on the 23-24 plan. Personally, I was pleased to see the strong IG trading position as the CIRA for the trust, and that helped with our data security protection toolkit. And we did have a long conversation about our insurance provision and the increase in our CNST premium, which we did discuss during the planning round. So all in all, I thought it was a really positive audit committee. So I'll stop there. Happy to take any questions.
Thanks very much. Pete, any questions? No, thank you very much. That report's noted. Moving on again to Pete, Collaborative Committee Assurance Report.
Yep, so again, I'll put up the key highlights from the Collab Committee for me. Were at month 4 as a collaborative, we had a balanced financial position, which is always pleased to see. We have seen a bit of a turnaround, actually. We've seen a significant reduction in the non-block bed usage for our CAMHS patients, which was a historical area of pressure. But we are starting to see a slight increase in adult eating disorder bed usage. So we're just looking at that to try and understand the themes and trends. Priority planning workshops are taking place for all 3 work streams, and that will obviously inform the priorities for the rest of this year and future years, and we'll fit that into the planning round. And we signed off a number of documents at the policy in terms of standard operating procedures, etc. So again, I'll stop there, Caroline. Happy to take any questions.
Thanks very much. Any questions? No, thank you. That's noted. Moving on then to charitable funds, Pete.
Yep. So, you know, the bits I put out the charitable funds committee, we are seeing a bit of mixed performance on KPI. So a couple of green in terms of wishes being acknowledged and the operating costs being within budget. But obviously more worrying, a couple of reds in terms of actually fundraising performance. I know we've got a conversation later today. You know, the one thing I would update since this report was written, since the Charitable Funds Committee, I've been in dialogue with the Newby Trust about the 80,000 pledge for the Garden at Inspire. I'm pleased to say that they have confirmed that that pledge is still good, and we're in the process of keeping them up to date, and we'll be bringing that money back in. So again, I'll stop there. Happy to take any questions.
Thanks very much, Pete. And that's good news about the Newby Trust. Any questions? Okay. Nope. Thank you very much. That's noted. Dean, chairing your own committee. There you go. Workforce and Organisational Development.
Yeah, thanks very much, Caroline. Yeah, so you can see the assurance reports on there. Lots of good assurance comes through a number of the sort of subcommittees that we've got on there. I suppose just the things to highlight really, and this fits back into the quality report and the report that we had earlier on the Countess of Chester. As it happens, both quality and workforce happened relatively quickly after that. So we'd got at this meeting, it was the report from the Freedom to Speak Up Guardian as well. So we're just able to speak to Alison, and questions were asked about, you know, what people could do if they didn't think an issue was being taken seriously, and also what Alison would do if she'd escalated something that she didn't feel, was being taken seriously. And you can see on there that there are those other routes that people have got. So just worth emphasising those, I think. We also said with Here and Quality that we kind of anticipate that although the inquiry is underway from the Countess of Chester, there will be various bits of guidance, information that sort of come out over time, some on the clinical issues, some on the managerial oversight of those. And we've already had, for example, the fit and proper person test, and the requirement for organisations to review their Speak Up Guardians. We just thought at an appropriate point, it would be good to composite those bits of guidance that come out in a few months' time and just bring them back to the appropriate committee so we can see them as a whole and just keep a review on what it is that we're doing. And just with that in mind, just in terms of some of the decisions made, we just thought it was appropriate to do some more focused work on sort of DBS checks that are sort of out of time. This doesn't mean that people haven't been DBS checks. It just means that it's lapsed for a period of time coming through. And also just looking at, again, we monitor people in terms of the number of shifts that they're doing, the overtime, just to make sure that's not being excessive. And again, Lynn was saying that was probably timely just to have a look and see if there's even more stuff that we could be doing around that area. But happy to take it as read.
Thanks very much, Dean. OK, I can't see any hands up, so thank you very much. That is noted. Thank you very much. So we're moving on to item 36, which is reporting of committee business. I mean, this sort of came up earlier this year when we thought we'd look at, what was the most appropriate form that the board should be informed about the work of the committees to the board. And as you can see in here, we've asking the board to approve our recommendations that minutes should no longer be forwarded to trust board meetings, but should be made available on request to board members. That committee minutes will still go to the committee in which they were taken from, and that's really important that they are checked for accuracy and approved there. And we are looking at developing a board portal so that all the minutes for anybody on the board who'd like to see them can be seen them there, and other documents could be put on that portal as well, available to all. We're also suggesting that the executive management team minutes should no longer be forwarded to the board, as that's duplicated through other reports that come to board anyway. So we'll still have, and just to make very clear about this, as we just have the committee assurance reports coming to board, and that's a really important part of us as a board collectively seeking the assurance and understanding of the key issues that the subcommittees are looking at and keeping an eye on. So I'll take that as read. Are there any questions that colleagues have got? Stella, I don't know if there's anything else you wanted to add to this. I know you went out and benchmarked what was happening in other trusts as well, so we could see where we sat within that too.
Yeah, I did, Caroline, and the findings are detailed in that report, and a lot of the recommendations are based on what the other trusts are doing as well.
Thank you. Anybody got any questions? If not, I'll take that up. Oh, there's a round of applause from Mike. Thank you very much for that, Mike. Let's put this to the board then. Is everyone in favour of the recommendations as laid out in this report? Thank you very much. Brilliant. Good. Right, moving on then to the board strategic development meeting agenda. Now, since these papers went out, there have been some adjustments to the agenda for our strategic meeting on the 25th of October. I think I'm right that the updated agenda has been circulated, but just to reference here, we are going to have the Trust Strategy and Board Assurance Framework and the annual plan that were on the original agenda. They've been removed because we have dealt with those in other ways, and we've already today had with Oliver the new version of the BAF anyway, and a discussion on that. But what we have included, which partly arose out of our development programme we were doing with Real World earlier in the year, but also I have to say in terms of that listening to clinicians, we're going to have, Kwame is arranging for some clinicians to join us for lunch when we have our lunch at the next strategic board, and then after lunch a sit down and more, I suppose, formal discussion with clinicians to have feedback from them on the perceptions of the board, how we work, and anything else might want to raise in that conversation. So that's replaced a couple of items, and I think both Michelle and I have talked about at the strategic board looking for ways there and other ways we can make sure we increase our contact with not just doctors and consultants, but other health professionals and other staff across the organisation, and see where we can make sure we find the space to make sure that's provided for. But I just want to flag that to everybody today. Any questions? Okay, thank you very much. Fine, no items to escalate. I haven't been given any other urgent business. Review of the meeting. So Did the board members feel the meeting was effective? Were the reports accessible? Did they enable you to do what you need to do in terms of asking and understanding? Did you have the right amount of detail? Did people, was the atmosphere of the board a good one in which to take part and be heard and listen? Good. I'm seeing thumbs up. Anything else anybody like to mention about the board today? Thoughts for the future to take away? Phil.
Obviously, it's been expertly chaired, but it's been a large number of items. Perhaps it could have been, I mean, it is in there, but perhaps it could have been clearer that because there's a lot of papers that have already been to other subcommittees, and it'd be useful for that to be taken into account when they're presenting the papers, because that could have made things maybe a little bit more efficient to give other time to other bits that we hadn't been through, other portals of assurance. Just a thought.
Yeah, no, look, I will take that away, Phil. I mean, in the run up to the board, you know, quite often there's quite a lot of discussion back and forth actually about certain items that are coming on, and then certain items which may not have come on because they've gone to committee, but we just feel it's, for a public board in particular, it's important that we are seen to be obviously showcasing that those issues have been already discussed, and there's a lot of that we've made reference to today, but also for those members of the board who aren't on those committees to be able to have that opportunity as well. But I take your point. It's from one board to another. It's important that it's not just a done deal, that we actually reflect and think about these things and as you say, take into account where there has been detailed discussion and presentation at other board meetings, and I'm thankful for that as part of our process. Thank you. Any other questions, comments? Okay, any other thoughts about the board and how we've put things together and the outline and structure of the agenda? Please always feel you can get in touch with me at any time. I have to say it has been a long meeting, but we are actually 10 to 15 minutes ahead of the schedule I thought we might end at. So we haven't done too badly. So we'll close this meeting now and we'll rejoin for part 2. I'm doing a little chairs vlog in between time. So I suggest we come back as arranged if everyone's happy for 1 o'clock. So everyone gets a good break before we go on to part 2. And then we've got a REMCOM later on. So James, if you could just stay on with me so I can sort out what I'm doing about this video vlog. And everyone else have a nice half hour. Cheers. Thank you.
Thank you. Well done, everybody. See you soon. Bye. Thank you.